That's the best way to get attention, have a technology difficulty. But good morning, everyone. Look around this room. The energy, the expertise, the commitment to change that all of you represent is exactly why today matters. We are thrilled to have you here. On behalf of Dr. Creasy Finney Harrison, the Dean of the Jane Addams College of Social Work and the Director of the Jane Addams Center for Social Policy and Research at UIC, it is my absolute honor to welcome you to the third annual Behavioral Health Crisis Continuum Forum. 3 years in, and the momentum has never been stronger. I'm Dr. John Holton, Director of Strategic Initiatives for the Center for Social Policy and Research and co-principal investigator for the Behavioral Health Crisis Hub, the proud academic partner to the Illinois Department of Human Services Division of Behavioral Health and Recovery. I won't say that twice again. This work is personal to me, and I know it's personal to many of you in this room. I want to pause and offer a heartfelt thank you to our event sponsors, the Illinois Department of Human Services, Division of Behavioral Health and Recovery, and SAMHSA. It's a statement of values. Days like today don't happen without their support. Now here's what I'm most excited about. Our team has built a day that is dynamic, thought-provoking, and built for action. This isn't a sit back and listen kind of forum. This is a roll up your sleeves, speak your truth, and figure this out together kind of day. We're here to push forward the Illinois Behavioral Health Crisis Continuum, and every single person in this room has a role to play in that. So be present, be open. The opportunities today bring are real. Let's seize them together. Now it's my pleasure to introduce and to hand things over to Allie Lichterman, the Crisis Community Programs Administrator for the Division of Mental Health and Recovery, who will share her welcoming remarks. Allie?
Thank you so much, Dr. Holton. I'm short. Good morning. On behalf of the Illinois Department of Human Services, Division of Behavioral Health and Recovery, I promise we will not keep saying that over and over again. I'd like to extend my gratitude to all of you for taking the time to join us today. The central organizing principle of our crisis continuum is simple. Get individuals in crisis the right resource at the right time. But the folks in this room, more than almost anyone else, know that making that happen and getting it right every time is incredibly complicated, high stakes, and important work. To our crisis service providers and first responders in the room, thank you. Thank you for providing Illinoisans in behavioral health crisis or other crisis someone to contact, someone to respond, and a safe place to go 24/7, 365. Thank you for doing the difficult and necessary work of triaging crisis calls, and thank you for partnering with us at IDHS and the Hub to connect all of these pieces. I want to acknowledge our many CESSA Statewide Advisory Committee and Regional Advisory Committee members in the room. If you want to raise your hands. Thank you for being here and for the work you are doing to make connecting 911 with our behavioral health crisis continuum possible. And I would also like to thank and acknowledge elected officials and government partners who have joined us today. Thank you for your dedication to serving our communities across Illinois. To Representative Lindsay LaPointe, State of Illinois Chief Behavioral Health Officer Dr. Inger Burnett-Ziegler, Statewide 911 Administrator Alicia Atkinson, Cook County Health Chief Behavioral Health Officer Dr. Thomas Nutter, and Jennifer Brothers, Executive Director of the Cook County Health Office of Behavioral Health. And now I'll turn this over to Dr. Lorrie Rickman Jones, Director of the UIC Behavioral Health Crisis Hub, for her welcoming remarks, and also want to say a thank you to her and her team for making today happen.
Thank you, Allie. Good morning and welcome to Chicago, everyone. We ordered good weather for you and it, did what it was supposed to do. And welcome to our third annual Behavioral Health Crisis Forum, Advancing CESSA Implementation, Active Engagement and Collaboration. I'm Dr. Lorrie Jones and I'm the director of the Behavioral Health Crisis Hub at Jane Addams College of Social Work. I'd like to thank my colleagues for their welcoming remarks, Dr. Holton and Allie Lichterman. Thank you all for being here. Also like to thank our sponsors, and I'm not going to do the behavioral health thing that John messed up. And to our speakers who traveled from near and far to be with us today. What an incredible gift to share your expertise in this room today. And finally, I'd like to thank my team. I'd like them to all raise their hands. This is a lot of work putting this on, and they did this, in record speed, so give them a hand. And Sarah Ridner from SASU, who did an extraordinary job leading us through this effort, so thank you again. As I said earlier, this marks our third year of sharing knowledge and celebrating this important systems change through our forum. The interest and response to this work has been overwhelming, and because we've had to limit our in-person attendees this year, we're in a smaller space than we were a couple of years ago. We are streaming the morning panel so our partners across the state can benefit from the expertise of our speakers. Those of you who are here present in the room are here because you've demonstrated interest, commitment to this work, and we support your continued growth as leaders of this change process in Illinois. And now I'd like to ask you to picture something. It's late at night. A phone rings. On the other end is a mother. Her voice is shaking. Her son is in crisis, and she did not know who to call, so she called you. You answered the call and tried to advise her to have her son call 988. But she was too frightened about what would happen to her son. Then you advised her to start with a call to 911. She had the same response. She felt paralyzed. She didn't know what would happen next. She was frightened, anxious. She only knew that she needed help. This was a true story that was recounted to me just last week. It was heartbreaking. Now let's think about that situation. Why was that mother afraid to use the services available to her? What does that say about the system we've built? Does our current crisis system response bring care or more fear and confusion? Does it bring compassion or escalation? Healing or harm? These are the real challenges before us. For decades, we've been building the pieces of that system. 911 has been answering calls since 1968, and the precursors of 988, the Suicide Prevention Crisis Hotline, since 2005. Our mobile crisis team since the 70s, and living rooms in Illinois since 2010s. But despite these advancements, we know 29% of persons with serious mental illness in the U.S. had police involved in a pathway to care. Too many people, some researchers say at least 1 in 4 individuals that are fatally shot by police had a serious mental illness. People with mental illnesses are overrepresented among those arrested for misdemeanor charges, and once they enter the criminal legal system, people with serious mental illnesses stay longer. A disproportionate share of the burden of this problem is shouldered by persons of color. And finally, 50,000 commit suicide each year, and others lose their lives while a crisis is being managed. Further, they enter these systems over and over again in a revolving door of insufficient and inadequate services, crisis responses specifically. Our emergency response partners have had to fill a void in our system because behavioral health crisis services were not there. Law enforcement and paramedics have had to become de facto crisis workers, often without the training and expertise, but yet willing to step in. And I think Chief Barden, I heard you say that on your podcast Raise your hand in the room, please. There. Yes, thank you. Yes. So we must, we can do better. We can do better, and we must do better. For me and for many of you, it's a moral imperative that we do better. So we must ask ourselves, why should persons experiencing a behavioral health crisis be treated differently than a person experiencing a heart attack or stroke? In the words of our CESSA partners, just like police are not appropriate care providers for a person experiencing a heart attack, police are not appropriate responders for people experiencing a mental health crisis unless there's a public safety concern. And that is why CESSA, the Community Emergency Services Support Act, the act that brings us here today, matters. And so here we are in our 4th year of implementing CESSA, an important initiative that is designed to transform our system, making a course correction, if you will, that will evolve our crisis system so it's efficient, resourced, and most importantly, well coordinated with our emergency response partners. A system where a behavioral health crisis is met not with uncertainty, but with the right response, an appropriate, supportive, and clinical response, no matter what door people enter, be it 911, be it 988, or another crisis line. So let me take a few minutes to share with you the current status of our CESSA implementation. And I've got a few slides to just follow along. To level set a bit, I want to review the very basic terms what the CESSA legislation requires. It adds an alternative response option for 911 when responding to behavioral health crisis. It directs our 911 call centers, or PSAPs, to provide callers seeking emergency mental and behavioral health response with mobile mental health services when appropriate, without engaging law enforcement unless there's an ongoing criminal activity, a threat of violence, or assistance is needed with involuntary transports. All emergency services, including any alternative behavioral health responses, must be provided in the response time that's appropriate to the care requirements, and requires responder training, a lot of it, that's mandatory, other that is optional. And so this could not happen, and the statute does identify partners that we must work with. And so the Division of Behavioral Health and Recovery of DHS is central to actually leading this effort. And as John said, we are the academic partner at the university to help stand up this work. The Department of Public Health, Illinois State Police, the 911 administrator, who is an invaluable partner in all of this, and the Medicaid Authority, Department of Health Care and Family Services. Other partners include law enforcement, fire emergency medical services, behavioral health advocates, local government, and the partners that are actually in the trenches every day lifting this up are public safety answering points, our PSAPs, our 911 call centers, behavioral health providers, and our 988 suicide and lifeline contact center, specifically Centerstone. Now, to recap our model in Illinois, which differs from other models that we hear about, particularly when our first panel talks and Gabriella talks about the work that she's doing. In our system, we do not dispatch directly from 911, although many jurisdictions do. We will hear again from Gabriella soon, but we instead leverage the 988 system to both de-escalate low-level calls when they come in, and they can dispatch for mobile crisis response for those calls they cannot de-escalate, and for second and third party calls. So the top line of this graphic depicts the historical system of reliance on police and EMS, and remains the current approach for those higher risk calls. The second level represents the 911 transfer to 988 and possible dispatch to MCRT. And this is our roadmap. Depicts some of our programmatic milestones in the journey for full implementation to 102 counties across this state and 169 PSAPs. And so the first, we had to create an organizational structure. Part of that was defined in statute. Then we had to develop a training, a risk level matrix to identify which cases could be pushed to the mental health system, new protocols, working with our protocol vendors. We pre-tested protocols and piloted the processes. We modified processes based on the pilot results, and we started implementation, with implementation expected to end, at least the first level, by July 1st, 2027. So this is our organizational structure. We have a statewide advisory committee that is broken off into subcommittees, protocols and standards, which is actually looking at the protocols. We have 3 protocol vendors that we're working with: Priority Dispatch, Total Response, and APCO. We have actually had to work with them directly to have them alter their protocols to allow for this behavioral health response. Technology and data, all the data elements that we're wanting to report, and we're really pleased that we have a database structure in place. So we're collecting information both from the mobile crisis response team, from the 911 call centers, and from the 988 system. So we'll be able to track cases and look at them holistically. And training and education, to develop all the training that's necessary. And all of this is pushed out to our 11 regional advisory committees, which are across the state. So briefly, over 35 trainings have been made available on demand through our learning management system. 7 are required for 911, 988, and MCRT, including de-escalation, respectful interactions with persons with MIDD and autism, the power of language, and some of these must require the involvement of persons with lived experience. This is our risk level matrix, which helped us define which cases would be transferred to the mental health system. It's a tool. It's not actually used, but it's a tool that helped us with our work with the protocol vendors. It identifies 4 risk levels. Primarily levels 1 and 2 and some of 3 get transferred to the behavioral health system. We had about 21 PSAPs involved in the pilot, and you can see how they're broken down. We purposely used urban, suburban, and rural areas, small PSAPs, medium size, and large sites. And 85 sites are currently participating in the implementation. So they're actively engaged in doing what they have to do to implement CESSA. We do problem solving with the PSAPs and create policy issues as we go through this, as they arise. We provide technical assistance to all the PSAPs, 988 and MCRTs. We are expanding our communication strategy, advancing data collection, and dashboard development. And so we have 27 active sites now, 27 sites that are actually transferring calls. And I'd like for people in the room who are working at those sites, please stand. I've got a slide that's supposed to show, this is the picture, by the way, the graphic of where they are across the state. The next graphic shows all 85 that are across the state in process in various stages. So I'm going to try to name the PSAPs that are here. CENTCOM East and West, Illinois Valley Regional Dispatch, Lyons Township area, Sangamon County. You're not standing. West Central Joint Dispatch, so, and McLean County. Please give them a round of applause again. They are really the leaders of this in Illinois. They are our ambassadors to our change. And similarly, they had partnerships with the following MCRTs, Mobile Crisis Response Teams, AID, raise your hand. There you go, thank you. LifeLinks, Memorial Behavioral Health, One Hope United, Presence Ascension, Rosecrans, Mississippi Centers, and Thrive Counseling Center. Let's give them a round of applause. And Centerstone, again, they're one of our contact centers They are the largest, and they serve as our primary in many regions across the state and our backup for the entire state. And they are actually doing the transfers to MCRT. And we owe them a debt of gratitude. Center student in the room, let's give you a hand. Okay, so next steps, we're continuing to roll out the next 84. We've got 84 more to go, and to get the rest of the part of the 85 that still have not gone live, to get them to go live. And so that's what we'll be doing for the next year. We're using a cohort model, releasing the sites in cohorts. We've got 2 more cohorts to do, one in July and one in the fall of October. These are some of the things that they have to do in order to go live. Make sure all their staff are trained, updating the CESSA-related protocol software, updating the phone system to allow direct transfers to 988, updating internal policies, landscape surveys, data collection reporting, and collaborate with their community partners. So there's a lot that they need to do to stand this up. And this is, last slide, is just our website. If you are at all interested in knowing more about what we're doing, it's a great resource for how we're moving forward. So the main goal of this conference, ladies and gentlemen, is to affirm our commitment to this work and to press through the many challenges of implementing such a complex systems reform. I know many of you have spent decades in the trenches doing the good work, hard work in your respective fields that has brought us to this moment. And because of that, we are ready to move forward, to elevate these conversations, to advance the work, and to reaffirm our shared values that unite us. Everyone, especially the most vulnerable among us, has the right to the most appropriate care, especially in a crisis. Think about that for a moment. Imagine it's your child, it's your spouse, your parent. That changes everything, doesn't it? Moving forward also means taking the time to truly learn about one another, the different missions, the different work cultures, the different languages that we speak. When I started this work, I'm a behavioral health person, I've been so all my career. I had no idea how 911 centers operated. I didn't know what a CAD system was, or incident codes, or protocol vendors. That was not what I knew, not my world. And I've known law enforcement colleagues who thought lived experience meant working a beat, not peers in service. We don't share a lexicon. We come from very different worlds. But here's what I believe. Despite our differences, we share the same values and the same mission. We want our family members to get the best, most appropriate response, especially in their moment of greatest need. We want that mother to feel confident, not afraid, when she reaches out for help. We want a system of care that is truly responsive for our families, our friends, and our neighbors. So this is my challenge to you. Rise up with greater readiness, stand with greater determination, work together, collaborate boldly, and let us build a behavioral health crisis response system that our communities deserve. So thank you, and we'll look forward to the rest of the day. I'm going to bring Peter back up to go over logistics, and welcome.
Good morning. My name is Pete Eckert, and I'm on the team with the behavioral health, with the behavioral crisis. Oh my God. VHCH, the crisis hub at UIC. I'm really excited to be in the room and see all of you and be a part of this. Lorrie's asked me to give you an overview of the logistics, and so I'm going to do that before I have the honor to introduce our keynote speaker. So it's all in your agenda, so you can ignore me for the next 30 seconds. We're going to start off hearing from Chief Payson, and then we're going to have 3 panels in the morning, one each focusing on a different aspect of the behavioral health crisis system with 911, 988, and mobile crisis response. We're going to have a break for lunch. It'll be right in this room. If you had the big breakfast, you probably won't be hungry, but we'll have lunch anyway. During the lunch, we're going to encourage you to consider questions that have resulted from the morning, and then we'll have the opportunity for our speakers from the morning to respond to a few of your questions near the end of the lunch. In the afternoon, you're going to see a bunch more of me because I'll be emceeing the afternoon panels. And then finally, we're going to end the day with a reception on the terrace that's down on the second floor. As I indicated earlier, we are live streaming the event. Hello, live streamers. Also, that recording will be posted afterwards, so hello to you folks who found us after the event. We're really glad that we've got a lot of people watching. Bathrooms are on both sides here, right outside the place where you entered off the elevator. You should have gotten a parking pass if you asked for a parking pass, and if you didn't, circle back around at lunch and you can pick one up there. Because you're on a parking pass, you need to make sure when you leave to use the Taylor Street exit. That's where your parking pass works. Apparently, if you try to leave elsewhere, it will not. If you need a quiet space for a moment to yourself or make a phone call, we recommend that you go back down one level to the second floor. That place, there's a large, comfortable lounge with plenty of seating. I also saw little pods for naps, which please don't do that. We want you to come back. If you need anything today, please reach out to the folks wearing these blue staff badges. Raise your hand, staff, just so you can be seen. They're scattered throughout the table. And apparently, even though we all carry hotspots on our phones now, if you want the guest Wi-Fi, ask one of us. We just got it right before we started today. For speaker bios to learn more about folks, that's on the same website that Lorrie pointed to at the end of her remarks. And you can also get there by scanning the resources QR code at your table. For folks who are in the room, not live streaming, we'll invite you to take part in an evaluation at the end of our session today. And so there's a paper version and there's a digital version. You'll see boxes as you leave where you can drop them off. You can also use that same QR code, and that'll get you to the digital version. We're also going to be using a tool called Mentimeter. If you were with us 2 years ago, we did exactly the same thing. So even though I don't normally encourage folks to be on their phones at meetings like this, we would invite you to use your phone now, hit that QR code that's on the screen. We're going to use this for a few times today. We're going to use it to collect your questions, and then in this afternoon, we'll be using it again. And so feel free to use that. I think we've got, if you get there, there's a question or two that you can answer. So you go to menti.com, hit that code, or use the join code. And then I think the first question is about where you're from geographically. Yeah, the exact question is, where are you coming from today? And I think our ACE team will present the results of that as you enter it. ACE team, oh, look at that. There it is. Where are you from today? So no surprise. The biggest number of folks are from Chicago, but Northern Illinois is rapidly trying to catch in. You know, let's get those DuPage people signed up. Metro Chicago, Central, Southern, and outside Illinois. I would guess that most of the outside Illinois are probably our speakers, but I'm really grateful for those folks in the Southern Illinois. We know it takes a lot for you to make the trip, but you know, CESSA is a statewide initiative, and so it's really important for us that you made the trip. Thanks very much for that. So I'd like to take a chance to give Chief Payson a chance to walk up here. I've had the honor of watching him online, and I just want to tell you a little bit about him because I think it really sets the stage, not just for his remarks, but for the significance of having a diverse participation across the crisis system. Paul Payson is the former chief of police in Denver, Colorado, where he rose through the ranks of the department up to his appointment in 2018 as the chief. During his tenure as police chief, Paul Payson led the development and expansion of innovative solutions to address complex public safety issues, including spearheading and creation of the Support Team Assisted Response Program, the STAR program. One of the very first things I remember reading about when we started this journey in Illinois. So his program also included outreach case coordinators, including case managers, and the domestic violence prevention program. He directed a significant expansion of the mental health clinician co-responder program, the law enforcement assisted diversion lead, the implementation of a forward-thinking use of force policy, and training for all of these initiatives. Chief Payson also created multiple new specialized units that you can read in his bio. Again, as a reminder, all the bios are online at our website. Chief Payson holds a Bachelor of Science in Organizational Leadership and a Master's in Homeland Security and Defense from the Naval Postgraduate School, and is a graduate of the FBI National Executive Institute, the FBI National Academy, and the Senior Management Institute for the Police through the Police Executive Research Forum. Chief Payson served in the United States Marine Corps and is a veteran of the Gulf War. It's such an honor to have you here. Welcome to the 2026 fair.
Well, thank you for that warm introduction. I appreciate it. After hearing Dr. Jones speak, I was just going to come up here and say ditto. I loved everything that I heard, but I also like that we had a little bit of audience participation before we got started, so we're going to continue a little bit of that. Law enforcement in the room? I see a couple. All right, great. Parents? Thank you, thank you, thank you. I appreciate it. Has anybody ever had to call 911 or 988 on a loved one? Thank you. First, I wanted to open by saying the work that you do is important. The fact that you're here matters. Somebody from the outside in Colorado really appreciates what you all in the state of Illinois are trying to accomplish. I guess the word trying should be cut out of there. What you are accomplishing in the state of Illinois. To get to the why, I'm going to give you a little bit of a how first, and my how is more of a story of how we in Denver implemented what we call a continuum of crisis care. So this, let's jump into the Wayback Machine together and go back to 2014. We started a process down in my favorite neighborhood in Denver, Colorado, and that's the Sun Valley neighborhood. This is a neighborhood that data indicated was not only the poorest neighborhood in the entire state, but also the neighborhood that had the highest concentration of mental health challenges of any statistical neighborhood in the entire state. Ripe for study. And we had plenty of groups that came in on the white horse and said, hey, we're going to do something. They'd show up for a couple of years, and then they were gone. In the police department, you're not gone. We've been there. We predate the city of Denver itself. We've been around 165 years. the police department, the fire department, emergency services, that continues whether or not it's a grant-funded program or not. So as a young lieutenant, we took on this challenge, and can't really do too much about solving poverty from the public safety side of things, but we wanted to look at a new approach to address mental health. And here we worked with community-based partners in order to have a community-based response to this challenge, going door to door to help parents and families and children address mental health issues. This is 2014. A couple of years later, we were early adopters of co-responder programs, started with 4 teams, and saw how effective that was. We quickly realized that these calls for service, these people that are in crisis, that there are better ways to get folks help. So we saw the value of that, and then in 2018 we started conversations about what later became the STAR program, Alternative Response. Again, this is something that has happened in other places like Eugene, Oregon, but it was a radical shift for us and many people. We started working together with primarily community-based organizations, Servicios de la Raza, the Denver Justice Project, who was famous for suing the Denver Police Department and very successful at that. Black Lives Matter 5280, Homeless Out Loud, the Harm Action Reduction Center. So a very wide perspective of different groups that are out trying to help people. And it was critical that we worked in a collaborative way with groups because it lent credibility, but it also, if we didn't work together, could have sabotaged the entire program. We sent folks off to different parts of the country, including Eugene, Oregon. We studied a hospital-based response out of Miami, some of the work that was being done in Houston, and had monthly meetings in order to try to create what we ultimately brought together. We recognized that PSAPs, that dispatch, was a critical component. Often we refer to them as the hub of a hub and spoke type of approach, and got them early into the process because who you send on those 911 calls was critically important. A lot of work, a lot of infighting. I mean, this wasn't rainbows and butterflies by any means. There was a lot of challenges when you bring different groups together, and who owns the program, where the money goes. Nonprofits work really hard to keep the lights on and the doors open, and money is a big part of that. And we had one group that said, give us $3.2 million and we'll run the whole program for you. We did it for 0.2 at $208,000 for the program. We also recognize that this continuum of crisis care, yes, we're talking about alternative response, but it's bigger than just one component. There's multiple components here, and Dr. Jones spoke on it. So if Paul is in crisis, and I'm armed with a weapon or I am combative, that is a co-responder call. We can respond, de-escalate the situation, get Paul the help that he needs. We can high-five, everything is great. If Paul is in crisis and it's nonviolent, that is a STAR call. The STAR van, no police officer, a trained mental health clinician, and a paramedic respond, de-escalate the situation, get Paul the help that they need. That is wonderful. We can high-five and be super happy with the results of that. But what happens next week? What happens next month? And we were very intentional in creating this, that we brought together case managers. We call them outreach case coordinators. And they were assigned one in each district, one in headquarters, and one in a juvenile response area as well. Because it's great if we can de-escalate Paul, regardless of who responds on that, but The real magic is how do we keep that crisis from continuing? How do we make sure that we're not calling 911 or 988 and getting Paul the services and help that he needs? So very proud of our outreach case coordinators. They get exactly 0 credit in our continuum of crisis care. Everybody wants to talk about STAR, but all of the components are very important here. On building this program, we launched STAR after 19 months of working collaboratively on June 1 of 2020. There was a couple of things going on in June of 2020. Not the least of it was the protests that we saw worldwide, including in Denver, regarding the murder of George Floyd. It was originally scheduled to start on August 1. However, there was that little pandemic that was going on, and we weren't sure we could keep 2 people in the same car safe. So we pushed it back to 3 months to June 1, once we were able to secure enough PPE and things of that nature. The outreach case coordinator started June 30th, so we recognized that it was really important to make sure that we had folks that we could do a warm handoff with, and then we worked over the next months and years to utilize the assistance of our nonprofits and our community-based groups in order to not only have a case manager who can do that warm handoff, but actually a place where we can get people the help that they need directly from either a STAR van transport or a co-responder transport. So it was a big, heavy lift, and we were really looking at the overall picture when we were beginning to start this entire process. I spoke a little bit about the challenges. It sounds when you speak on it and like, oh wow, that was quick. Just like you're running into different challenges here, there's many different hurdles that you need to accomplish, and very few of them are easy. But the way to do it is pointing to the North Star. And the reason that you are all in this room is you've already identified what the North Star is. For us, in each one of those meetings, and multiple times during these meetings, we would have to point to our North Star. Our North Star that helped us get this accomplished was better outcomes for individuals in crisis. Better outcomes for individuals in crisis. Who can argue with that? I believe that the continuum of crisis care that we were able to accomplish, even with different folks pulling in different directions, is something that we as a city are very proud of. We've been able to share our model with other places across the country, other places across the globe, including Canada and Scotland. Very proud of that effort in order to do that, but we can never lose sight of why you're in this room. Now, why it's important to law enforcement. In our program, we recognize that early on, right? I took you in that Wayback Machine to 2014, realized that we had a neighborhood that was challenged for decades, recognized that just sending police response over there wasn't changing the situation, that we had to look at it from a whole different angle. And I'm very happy to say Sun Valley is transformed in a very positive way, not only for the people that live there, but even what it looks like today. So it's critical that law enforcement plays a role. What that role is, it depends on how you're putting that situation or how you're putting your program together. For us, we were actually the lead role in this. We recognized that there was a challenge. We recognized that there was a better way to do things. And after we got it up and running, It was a Solomon and the baby moment, and we had folks that said, okay, this is great that you put this together. Again, this is in 2020, and they said, we think it should be in public health. And instead of splitting the baby, we gave our baby away, and the baby has been raised and doing great. So law enforcement does play a role in this. When I asked folks to raise their hand from law enforcement, I would guarantee that most folks in public safety, firefighters included, they would much rather handle that structure fire, the car accident, the robbery in progress than the naked person running down the street who had urinated all over themselves type of call. There's not too many officers that are sitting in their car saying, ooh, I want that call. Generally, it is the other way around. For us, it was very effective as far as, we had lots of quick wins on this, which is a good thing. Our co-responders became part of our DPD family. In fact, the first 30 co-responders that we had, only 2 of them ever left, and both of them left to become Denver police officers. They got hired as police officers. So we grew a very close relationship with the co-responders, and that continues. And then when we implemented the STAR program, we did it in a pilot district downtown. We called it the Lollipop, downtown and South Broadway. And as police chief, I would go visit each one of the districts, and immediately each one of the other districts, when you're talking to roll call, hey, when can we get that in our district? When can we have the STAR program here? So we did it pilot for a year. We recognized right after 6 months that this thing was working. We brought researchers in. Stanford did a study on it. It was great. We proved that it was effective in getting those better outcomes for individuals in crisis. One little caveat that I'm going to sneak in real quick, and this generally will upset at least half of the room, but for law enforcement, STAR, alternative response, or Eric, maybe I've heard you say it, response, is different. We were able to expand co-responders in STAR to every single district, 24-hour-a-day coverage with co-responders, 20 hours a day with the STAR van. But STAR, alternative response, is not a replace the police program. STAR is not, if I had 100 STAR vans, it would not reduce one murder, one shooting, anything along those lines. What the data, what Stanford, totally independent, shows is it's public order crimes that it helps to address. These are trespassing calls. These are calls where individuals are in need but not committing those person types of crimes. So there is a balance. It's important that we all know and understand this. This is not replace the police. This is better outcomes for individuals in crisis. Why all of this matters. I was very proud that we led the creation of this massive program, this continuum of crisis care, so we could help folks in Denver. And it's been very effective, lots of buy-in. 29% of all of the calls for service for STAR are actually generated by Denver police officers. They recognize the value of it. But why the work you're doing matters is March 14th of 2022. So nearly 2 years after we had started STAR, outreach case coordinators, our assessment intake diversion center, all of these fancy programs, I called 911. I called 911 for my child. My child was in crisis. My child lit a fire in their bathroom, put the ashes on their face, was talking about helicopters and snipers. On his 22nd birthday, I might add. And this didn't happen in Denver. This happened 1,000 miles away in a very progressive city that I would have imagined had some similar types of responses that we had. As a police chief at the time, I had the phone number to the police chief in said city. I had the ability to get a hold of the PSAP in that city and talk to the officer on his way to interact with my child who's in crisis. It horrified me. I got a hold of the officer and I asked, do you have a co-responder program? Is there a mental health professional that you could use to help? This is not how my son is. My son is not violent. And the officer said, what? A mental health professional in my car? I would throw them out. Aghast. This is the person that's getting ready to talk to my child who's in their in a mental health crisis, their first break of the situation. My child did not get the help that they needed. It took flying up to the city, multiple calls to the police chief, multiple responses. This didn't get fixed in one call or two calls. It was the third call when we were finally on scene there that we were able to get my kid the help that they needed. My kid was in a mental health facility for 11 days. This was real. This is not, somebody that didn't want to do their homework and was acting out by any means. So this is real. It put my entire family sideways. We did not know what to do. So even though we can create these great systems, we need these systems not only in Denver, not only in Illinois, we need these across the country, because we never know when we are going to call 911 when somebody that we love is in crisis. So with that, I applaud the work that you are doing. It matters. It has an impact. We've come a long way. We can be very proud of the progress that we've made. There's still more work to be done. So thank you so much for your time. Thanks for furthering your efforts in order to help individuals in crisis. Thank you. We'll be on panel so I can do questions and answers then. Sorry.
Dialing 911 can be a very stressful moment. Dispatchers in Marion County want to make sure that all calls are covered. Our Anna Chalker tonight shows us the new response to mental health emergencies.
It's the question every 911 dispatcher asks.
911, what is your location?
But now in Marion County,
Is this a police, fire, mental health, or EMS emergency?
a caller can request mental health services.
It helps people when they're going through tough situations, and it also helps us being able to ask the proper questions to be able to help them and assist them with what they need.
Dispatcher Paulette Riza Mendoza says she takes mental health calls almost daily, and the response requires extra attention.
The life of people basically are depending on us at that moment.
The push from her and other dispatchers, de-escalating situations before resorting to call in law enforcement.
And if we can avoid sending police officers to a run that is really not police related, that we want to be able to get the proper service there.
So what is that service if the caller does have a mental health emergency? Well, the city's clinician-led community response team will go to that caller's location, provide a safe environment, and walk them through that crisis, and then give them the next steps for support.
We're able to go directly to people wherever they are in the community and provide immediate support and services. I think that addresses a lot of barriers to access for folks.
It's not only licensed mental health professionals who intervene. but also peer support specialists in recovery who have gone through what the person is dealing with.
These are complex issues. A lot of times people are sort of at their wits' end, and so we can come in and direct them with our resources, to get help.
Having a peer on scene gives a sense of hope, if you will, because you're showing you're an example that recovery is possible. This isn't your lot in life.
A sense of hope that can come from just one 911 call. In Indianapolis, Anna Chalker, 13 News.
CLCR tells us tonight they respond to all nonviolent mental health calls, but police will be called in if the situation escalates.
So Dr. Amy Barden. Gabriela Solis Torres. And Phil McCarty. Please join me on stage. Sorry, Chief, we're putting you back in service right away. So we all know Chief Payson. Let me introduce Chief Dr. Amy Barden. Just Amy, okay. Who is the first chief of Seattle's third public safety department called CARE, Community Assisted Response and Engagement. She directs the work of Seattle 911, the CARE Community Crisis Responders, and Seattle's lead diversion and outreach teams. So we are very happy to have her. She holds advanced degrees in ethical leadership, administration, and organizational learning, most recently completing a doctorate at Vanderbilt University, where she honed skills in data science and behavioral health research. Prior to this role, she spent 20 years in leadership at human service organizations in Washington State, Oregon, Pennsylvania, and Ohio. Please give us, Amy, a round of applause. Phil McCarty serves as director and of the Jacksonville, Morgan County. Is that correct? EMA director, overseeing regional tri-accredited 911 operations for Morgan, Greene, and Calhoun counties. West Central Joint ETSB operates one of only 2 tri-accredited dispatch centers in Illinois, and Phil's career spans from frontline EMS field training to executive oversight of a multi-county emergency communications center, including leadership and implementing Illinois' CESSA initiatives and integrating priority dispatch protocols into its regional operations. Phil is one of ours and one of the first leaders in Illinois who participated in the pilot, and we're really so proud of the work that he's done. And welcome, Phil. Please give him a round of applause. And last but not least, Gabriela Solis Torres is the Director of Safety and Justice Alternative Response at the Government Performance Lab, GPL, at Harvard, where she established the Alternative 911 Emergency Response Initiative, dedicated to strengthening alternative 911 emergency response by providing technical assistance to governments, evaluating promising solutions, and disseminating learnings that facilitate adoption of programs at scale. Prior to Gabriela's work at the with the UCLA Latino Policy and Politics Initiative to conduct research to help advance advocacy efforts pertaining to domestic violence issues affecting communities of color, and served as a co-director of case management for Bruin Shelter, a shelter for college students. She holds a BA in Gender Studies and Sociology and an MSW and MPP, that's a new one for me, at UCLA. So welcome, Gabriela, and you're going to start us off today. So Gabriela, please tell us a little bit about the Performance Lab and the work that you're doing there. So give Gabriela a hand while she gets herself ready for the podium.
Testing. Can y'all hear me all right?
Yeah.
Yeah, wonderful. Okay, I have slides because I was given the opportunity, and if you've ever worked with the GPL, we always have slides. So, let me move this up a little bit, actually. Oh boy. There we go. Okay, wonderful. So I just click. Yeah, next. All right, wonderful. So I'm going to give a quick overview of a little bit about our work at the Government Performance Lab and some of the work that we've been doing on helping set up an emergency response system that sends the right response at the right time. I should have added a very brief national overview is what I'm going to attempt to do right now. I'm starting my timer so I don't go over here. But the Government Performance Lab, so we help jurisdictions connect residents to the right services at the right time by developing and implementing programs that divert 911 responses to 911 calls to other responses. These are things like unarmed community responders or behavioral health professionals. The majority of our work, though, focuses, and what I'll be talking about today, on the community responder model. So this is teams that are unarmed and are able to go to 911 calls on their own as a primary and first response to calls. And in this presentation, I'll do a quick overview on the 3 dispatch models that we see in the field, and then do a brief overview or like pull up on some of the findings from a very recent report that we just put out. So a quick dispatch model overview for you all. So in doing this work, so now we've supported about 35 jurisdictions across the United States to set up these types of programs. And we see that there are about 3 main models that are sort of like popping up on how these teams function. So the first is a fully embedded dispatch model where you have the 911 center is fully responsible for dispatching these teams. So it usually looks that they're answering calls and then they're sending and can directly dispatch literally the community responder team, which usually means that a police dispatcher or some other fire responder dispatcher is responsible for sending that call and take on the responsibility of managing the unit and sort of over and making sure that the team is safe and going about that. The second is there's a hybrid co-location model that we're seeing pop up also, where you have folks that are actually embedding specific dispatchers for this community responder team to be responsible for dispatching those teams, essentially. So you see that in Austin, in Phoenix, we have teams like this. So the call takers are your traditional 911 call takers, but then once it's identified that the call is eligible for a community responder team, they'll shoot it over to a different new dispatcher for that person to then handle the call. And then the third is a fully separate model. So this is, I would argue this is kind of what y'all are trying to do here, where you have the 911 center answering the call, identifying that it's divertible, and then sending it to a fully separate dispatch center that is located usually somewhere else, essentially. So we see that in Los Angeles, that set up a secondary PSAP for community responder team, for their community responder team specifically, and they sort of handle all of that. And I present these just, and the one thing I'll say in presenting these is that there's no one-size-fits-all approach. It really depends on what's going on in your local jurisdiction and how you're currently triaging 911 calls. So in this Los Angeles example, I think a lot of people are like, oh, a second dispatch model, like that's so rare. But in Los Angeles, what we saw is that LAPD will answer and triage all the calls, and every other first responder has their own physical secondary PSAP. So for them, they were like, you got to do what everyone else is doing, essentially, and they created that PSAP. So like with everything, there are 4 trade-offs that I'll just highlight very quickly. One is to really consider the interoperability of the model. That ranges depending on how you're doing that. But as I'm sure you all know from your experience, that interoperability is really key to making sure that your teams are successful. So think about how much are your technology integrated, how much can you see CAD notes across systems, what do folks know that they're getting into here? And then the 911 staff experience is something also very important. Again, like in the LA example, we were trying to create something that would feel familiar to the 911 staff and not try to create a brand new process, and try to sort of minimize some of that and then support it with a lot of training. And then the protocol and program design process, of course, if you're going with a fully integrated model, you are likely, or a fully embedded model, you have to adapt a lot of the existing protocols or sort of find a way to fit in within those, your program design within the existing protocols. Whereas you can imagine there's more flexibility if you have a fully remote option or a different location where you can actually like create your own dispatch policies once the call gets to your PSAP. And then the last, which is the unavoidable one of all of these, is the cost of all of this. Obviously, there is going to be differences in the model that you choose and the cost, so that really differs. We see differences based, or decisions being made based on cost across our jurisdictions. But I'm happy to answer any more specific questions about that. And then the last thing that I'll cover very quickly is just some brief highlights of what we saw in our report on how these community responder teams are currently performing in the field. So we did an analysis of 9 community responder teams across the United States and asked them actually to send us their actual program data. So we got all of that information. We cleaned it up, we synthesized it, and then we pulled it up to try to tell a story at a national level. So take a snapshot of teams across more than one jurisdiction, because up until now, if you wanted to know how a team was doing, you literally had to like go click into their website, look at their dashboard, and then go to the next one. So we were trying to do a little bit of a pull-up here. And what we saw, and you can access this report online also, so I'll flag that. But what we saw was in these 9 community responder teams, they were operating as first responders in their 911 system, so actually responding to 911 incidents alone. They were responding to a broad set of quality of life and behavioral health type 911 incidents. And then they were fulfilling their function as a first responder by resolving the calls that they were dispatched to. And then we saw also that they were rarely requesting support from police when resolving those incidents. So I'll quickly go through some slides with some graphs. So the first, you could see here, about 80% of the calls that these teams handled, they went out on primary responses, which is what we call that they were sent as the first and only responder to the incident. About 20% also is that they were either going as a joint response, so with police, with fire, with EMS, or that those same first responders were calling for support from the team on scene. And then we saw that there were predominantly 5 call types that account for 92% of the calls that these teams are going on. So you see those listed here. So we have mental health, welfare checks, unwanted persons, dispute and disturbances, and then medical calls. So the medical calls, I think, sometimes makes people feel a little uneasy, but these teams, some of the teams that we looked at actually had paramedics on their teams and could handle a little bit more complicated medical calls. And then the other finding was that the CRTs are successfully responding to and resolving these 911 incidents on scene when they're responding alone. So that was one of the big questions for the field, is like, can you actually send these teams and will they resolve the calls, or are they just gonna eventually call the police? Like, it's just gonna take them longer to call the police. And what we're seeing is that's not true. So 95% of the time they're clearing those calls off of the CAD without having to send back or cancel the call. And then when we do see that they're sending calls back, it could be for a lot of, or the calls are canceled, it could be for a lot of different reasons. We talked to the programs, they said, the caller called back and actually something else was going on. So we got new information how to cancel that. But again, as you could see, it happens very rarely. And then the last, the other one here is that they are actually resolving calls as when they're resolving calls as a primary response, they're rarely calling for backup. So 98% of the time they're not calling police for support when they go on these calls. And then the 2% of the times that they're going on, we talked to a couple of programs and asked them like, what's going on here? And oftentimes it's because the call had some sort of like higher level of psychiatric need, and in that state they needed police to do an involuntary hold, for example, or a transport or something like that. So it's not always because the call was dangerous or they couldn't handle it. But unfortunately, from what we saw in the data, most programs aren't collecting the why they're calling support. So if y'all are setting up your data, make sure to do that. Okay, I'll stop there, and then again, you can find all of this information on the internet, and you're welcome to talk to me after too if you would like.
Thanks, Gabriella. We're going to hear from Amy now, who leads one of the most innovative departments in the United States in terms of having 911 and the crisis response models under one roof, under your jurisdiction. So tell us what that's like and what that journey was like.
Sure. First, I have to say two things. One is that my new friend Leanne made a joke about between two ferns, and now it's all I can think about. If I launch sideways into comedy, that's why. Second, I just want to acknowledge and thank you all who have been working on CESSA. I do have oversight of Seattle 911. That's my main job. People are more familiar with the care team, which is the STAR type model. But 90% of my time is about trying to centralize and operationalize and elevate 911 dispatchers in the system. That, to me, is the point of innovation. If you can actually support this part of the continuum, actually treat these people like first responders who deserve all of the same supports, well-being strategies, liability protection, and respect, everything will change from there. And so I want you to know, I know this is about Illinois, I'm in Illinois, but you are changing the nation as you do this. I'm cheering for you. My husband said, are we gonna move here? Maybe, we don't know. But it's a really,
Come
really
on
big deal.
down.
Yeah, it's a big deal. So again, the design of my job is, frankly, 911 was pulled out in 2020. I didn't live in Washington at the time, but my husband was an assistant chief in SPD at the time, and he would tell you, it's just reactive. You know, there was just this idea that we need to spend less on policing, so they took out some of the major big ticket functions without a lot of thought about the interoperability of 911 CAD systems and first response. I arrived a couple of years later, and it was basically just hanging out without business supports, policy. It was actually quite a lot of legal risk in so doing. And then the council had elected to pilot an alternative response unit, 6 people, $2 million. They just kind of tucked the money in 911. I think they didn't know where else to put it. They didn't want to put it in the police department or the fire department at the time. And so it turned out to be, I think, a good decision made for the wrong reasons. It was interesting for me to arrive to start analyzing call data, to pull down the data sets, and I'm trying to answer, as someone with a background in behavioral health, okay, how many of these calls, I'm getting 900,000 a year, how many relate to homelessness? How many of these crimes correlate with substance use? And there was no way even to study it. So that's actually what really captured me. I thought, oh, if you use this as the data set, and then actually started to recommend diversified response units according to that data, that would be the intelligent path forward. And it should also be really flexible. In a city like Seattle, 2022, 2023, I lost 1,400 neighbors to overdose that year. Half were under the age of 40. And meanwhile, everyone's hopping around debating the perfect definition of harm reduction. We were going to break the homicide record that year, but that was 73 people. Egregious. But again, I was losing that many people every 2 weeks to substance use disorder. I learned that our 2 priority 1 call types are suicide and overdose. So those are behavioral health calls. So that became sort of the foundation and the urgency that I felt about this 911 redesign. I imagine a world where, again, I always say diversified response, because ideally you'd send the right configuration. There are many, many calls, I would say most, where in a perfect world, I would have a clinician, I would have a medic, I might have law enforcement on standby. Very often I would have a peer on standby, because I know that person who's already lived through it has credibility I can never have as Dr. Amy, whatever the titles, right? And so that's what we're moving toward in Seattle. I think that I love Gabriella. There are these different models. What we've done is a little bit easier in that the care responders are first responders by the legal definition. I was able to standardize pay with community service officers. They have an academy now. They have field training. And so the first responders, fire, EMS, care, and police, they're starting to interact the way that I want, where they just understand where they fit. We know that when somebody calls 911, fundamentally, it's limited what we know, right? If it's a third-party caller, I'm dispatching according to what somebody thinks they're seeing, right? It's just fundamentally imperfect. And so we have 988 as well. That's why that integration matters. Probably 30% of the time, we're gonna guess wrong. And so we just need this really frictionless, coordinated system where we can reroute to the different units or, again, call back up. And then the final thing I'll share off the top is that my deep conviction is that we need a system designed to break the cycle, right? So if you can make sure that 911 has a line of sight, if I think that I've referred over to lead and this person has a case manager, I think they've come into services, and I can see, oh, there have been more arrests than ever 6 months later, make a different recommendation. Right? We need to not be so prescriptive about, oh, this is mental health, so I'm going to send this unit. Sometimes it's been an officer, actually, who has the most trust with the person and the most credibility. And if I can know that, if that note is in the RMS, I can send that resource first or alongside the mental health resource. And so that's the lead contracts just came under my purview this year. And that's what I'm really excited about, is to hopefully be able to assure, again, as Paul so eloquently said, if this is your person and someone you love, you don't want the wash, rinse, repeat of 911 or 988 calls. We can do much better as a system.
Thanks, Amy. And I love, just write your questions down. Just hold your questions. We're going to get to those. I know you have many. I love your vision and the idea that you're creating teams to respond to whatever the issue is. So that's really laudable. Let's go to Phil, who, as I mentioned when I introduced him, was one of the ambassadors of change here in Illinois. And Phil, talk about your journey here in Illinois.
Well, the first part of my journey was today up here, and I saw more people on the road than live in my community. I want you to think about that for a minute. But in a serious note, I mean, I come from a community that is in an area of 1,100 square miles and less than 50,000 people. That comes with a whole nother set of challenges, very different than my friends to my left. We don't have the resources, but we also don't have the volume to create data to make sure that we're doing the right things. So how do we do that? I expect you're going to hear this repetitively today, because we've already heard it more than once, is collaboration. I'm not going to be Seattle. But my loved one, my friend, could be that person in crisis. And do they deserve the same similar treatment as they're going to get in Seattle or Denver or the city of Chicago? And I think the answer is yes, and I think that's where we need to be. Does it look the same? No. Does the end result come to the same? It very well may be. So how do we get there in a rural environment, similar, the same but different? I know none of those words make that probably gives somebody some anxiety, and I'm sorry. It's a collaboration that we meet and have with not only with their 590 providers, but also with our neighbors and our friends that are right here with me today. We talk to each other. Cohort Zero, I'm sure we have lots of sub-meetings about us because we're really difficult.
We talk about you all the time, Phil.
Yeah, that's what I suspected. But we have learned so much from each other through that collaboration, as well as through our sub-regional committees in our region, that we're just at the beginning. A little very brief subject. In our little town, we got a little fella that was sleeping on the park bench. I'm sure in some of your areas, like, oh, yeah, okay. Well, in Jacksonville, that's a big deal, folks. That's not okay. Fast forward, our law enforcement officer engaged our 590 provider who is embedded in our dispatch center. When I say embedded, like her office is not there. She stops in and says hi. She comes and visits. We know we put a face with that person. That makes a difference. The law enforcement officer sent him out. We got some care for the individual. He had dementia. He thought he was living at home. That's success. So how did that happen? It's no different than anything that any of you are doing or working on. It's what it means to work through it and then keep working at it. So that's my experience. I hope I don't see that many people on my way home when I leave tonight, but I suspect I will. Thank you.
Thanks, Phil, and thanks for being an ambassador for change in a rural area, which kind of points out the complexity of doing this statewide. And I want to recognize our colleague from Virginia. Where is she? There you go. Thank you for being here, who also has a statewide mandate, and I'm sure is dealing with many of the same issues of trying to stand this up, not only in large rural, suburban areas and urban areas, but rural areas where the challenges are very different. So thank you, and we're going to work through some of those. But before we get to more Q&A, let me go back to Chief Payson. You talked a lot about your experiences and the collaboration that you had to forge to get this done. But what were the specific messages that resonated, if you will, with your law enforcement colleagues and with fire and EMS? Are there specific things that worked with them in terms of trying to bring them along with you on the journey?
Without going too far back into what we talked about a little bit earlier, it was important for me to start in 2014 with the story because a lot of our quick wins led to understanding that this was possible. So working in close partnership with the co-responders just lent credibility to the officers that this is part of our DPD family, that they want the same thing that we want, and that skepticism that arose when they were first working with us quickly evaporated. And so that part really helped in the entire situation. We had I'm proud of Denver in many ways. It leans forward in a lot of different things. You heard my introduction with LEAD. We went up to Seattle in 2016 and copied some of the ideas that they had going on in order to just try to come up with better outcomes for individuals in crisis and just better outcomes. And seeing what's happening across the country and then figuring it out yourself is just something that, system-wide, not just police, but fire and EMS. For us, we put a paramedic in every STAR van, and working closely with the chief at Denver Health was seamless. We had that long history of working together. So that's not always the case. You heard me talk about the friction. Our friction was more a battle over control. We had nonprofits that wanted the whole thing because they saw a dollar sign associated to it. And again, that's horrible to say out loud. I understand why that is, but we had to come together with the service providers in order to figure out what was the best way to accomplish this.
And Amy, what about you in terms of what were the most difficult groups to collaborate with, and any insights on how best to message those groups to bring them aboard?
Yeah, I think the words really matter. The messaging and the framing of this movement matters more than I can express. I was sort of dropped in West Precinct. We have 5 police precincts in Seattle. That's where 911 is. And I was very internally focused and hopping all around roll calls, trying to figure out what cops didn't want to go to. And I don't think anyone knew what to do with me. Looking back, they were like, is she actually an abolitionist and she's pretending to be friendly? Again, then I married the deputy chief, and so they thought I was really masterful at getting buy-in. But in truth, I'm just a pragmatist, right? I do care deeply about people. I understand we have neglected prevention, early intervention, deflection forever. And so now we do have a lot of people who are going to need some sort of coercive abatement to the behavior. Now, I think the jails and prisons are terrible. It's a totally different forum. So I'm just more practical about that. What do you send first? What is the skill that is needed? Or I'm a huge fan of co-response. And because of that, and I think because I was so genuine, and I think cops can sniff out authenticity usually pretty fast, I was wildly supported by law enforcement that first year. It was amazing. As I launched this little pilot of 6 care responders, 88% of the first 1,000 calls were SPD referrals. I could hear it on the radio. It was like, Care 31, go. That's not us, that's you. And it was astonishing, and I was so optimistic for a minute. And then I started to bump up against the behavioral health system. As I talked more about 988 integration, it was like, no, we don't want to be anywhere around 911. And I was like, what the heck are you talking about? I'm with you. I'm trying to get the calls out of 911 where appropriate, but I also acknowledge that 911 is a mental behavioral health crisis hotline. It's not healthy people doing crimes. And so that's why you need these resources at every part of the continuum. I think we're getting pretty good now. Co-response in Washington is becoming ubiquitous, and that to me has been a very useful bridge, that if people understand, both in fire and police, that design, then it's just a step further to go, okay, and maybe sometimes you don't need the firefighter, sometimes you don't need the officer.
Yeah, thanks. Gabriella, what did you learn from working with the sites that you worked with?
Yeah, I think one thing that I've seen from the sites that we worked with, so I helped set up the team in Harris County, Texas, which is the HEART program that sits within the Public Health Department. And I think to both of your points, the messaging was incredibly important, but there the chief, I think, really aimed at reminding people, or like leveraging the fact that people go and pursue careers in public safety because they want to do the right thing. Like at the end of the day, they sort of chose this job because they thought they were going to make a difference and people were going to be healthier. And I really saw him like really leverage that and take the mission of like, we're here to protect and serve, and message it. And like sometimes that means handing the call off. Like sometimes that means diverting. And I think that went a really long way. The other strategy that I will say, and Amy sort of touched on this too, is that it really is important to go and talk to the folks who are responding to the calls, who are answering the calls, and say, like, what is the most frustrating thing that you're having to deal with? What are you showing up to that you don't have the skills? Literally every officer I've ever talked to has a story that they remember where it's like, I walked into the situation and I felt completely unprepared. It was scary. I didn't know what to do. I ended up arresting someone. I don't think that was the right thing. So I think once you sort of start talking to people within that framing of like, we're really here to help people, we all want to do the right thing, that's an extremely helpful strategy.
Thanks. Phil, what is it like in a small rural area when sometimes one person has multiple roles?
Well, I think it brings forward a challenge that is obvious, that we know everyone. That's somebody's brother, sister, sister-in-law. It's not a matter of, and I know the larger communities have that within the community as well. I wasn't born last night to understand that. The EMS provider may be also a 911 dispatcher, and I have a lot of volunteers in my communities. I only have 3 paid EMS transport agencies and 1,100 square miles. So I'm not saying that, but now we are telling them, you're going to these calls and we need you to change your approach that you're going to these calls with a little bit. As I came from as a paramedic, it's the best job in the world because I only had the patients for 5 to 7 minutes in Springfield, and there's the ER's problem. But also, we have to change that mindset, right? I just said it. I only have them 5 to 7 minutes. These calls are not 5 to 7 minutes long. We have to teach them and also remind them that they're going on these calls already. They're like, as recently as just the other day, our firefighter said, "Oh, we're not going to that." Like, you did last night. These are the same calls, but we're changing the mindset that they're going to, and that starts with changing the mindset in dispatch. That's what I have control over as we're adding a responder to the group, and that's really difficult. I think you come across that in all public safety. We're changing what we do. That's not going to happen overnight. We do that by being there, being present, building that trust, and following through with what we're doing. And when it doesn't go right, because it won't, there will be an incident where it's just not going to go right, and figuring out why it didn't and then fixing it. I don't think that's much different. It's just I have less data, less call volume. Less call volume for my telecommunicators means more training for me and my staff, because they don't get the volume. They get in the centers to my left, they get training by repeating. We get training because we have to continue, but the responsibilities are the same. The 911 caller expects the exact same thing in Denver and Seattle as they do in Carrollton, Illinois. And there's probably only a couple people in here that know where that is.
So, whole panel, say more about telecommunicators. We saw a little clip about what their job is like, and of course, it's very different. Those of us in the behavioral health field, they have to make rapid decisions. They're not staying on the phone for minutes and minutes, 20 to, I think the average call time, Centerstone, what is it, like 20 minutes on the phone sometimes? They have to make rapid decisions. And from what I understand, most of they're very committed. They want to make sure that the situation is taken care of, it's handled appropriately. And we're asking them to turn them over to a system they know little about. Say more about the concerns of the PSAPs, and what are the best strategies to get them to understand the value and importance of this work?
I'll start by quoting Andrew Damron, who runs Denver 911. I should publicly broadcast his contact information if you don't have it. He's brilliant and a really good teacher and trainer, one of the healthiest PSAPs in the country. When I was first in Denver and talking about, again, designing these protocols for STAR, he said, well, the challenge you're going to find is that dispatchers generally, they're trained to be skeptical. They're trained like law enforcement. What is the worst case scenario here? What if this is a gun? What if this escalates? And he said, what you're designing is something that's fundamentally optimistic. You know, people on the behavioral health side, we believe right words, right order, right skill set, right resources, we can get to peaceful resolution. And that's optimistic. And he said, the question is, can the same dispatcher hold the cynicism and the optimism? And I said, can they? And he goes, I don't know, Amy. Nobody knows. That's the thing, you know. And we talk all the time. There's a little group of us. We're always playing around with this idea. Do you need actual separate dispatch, right? My belief is probably not. Probably not. Probably we can use technology to assist in that decision making. We can stop having mandatory overtime, have healthier people. It's just like law enforcement, right? And emergency departments. We need a healthier culture where people are rested. And then I talk a lot about the feedback loop, where as an industry, we don't really know how to get the positive outcomes back to the dispatcher. They are exhausted. My shop's exhausted. We're going into FIFA. I don't even want to go home right now. Seriously, it's just a lot of work. And so you start to feel like, I just want to get this call off the board. You know, it's fine, I'm going to send cops, and then they'll figure out what to do with it. I'm a little unique in that I can hold them to account, right? When people say, how did you get 911 to start dispatching care? I'm like, that's me. I'm their chain of command. And so we will after action review and coach, and we've been very soft. We're not like performance managing it, so it's punitive. But we are trying to help people to understand, what is your bias here? Why are you making that decision? And do you understand that actually you had a greater likelihood of a bad outcome because you sent a gun and a badge when there was no reason to indicate you needed it? So basically, I just aired all of my concerns. I don't think I answered a question, but yeah, it is a challenge.
It was fun listening to you.
Yeah, it's therapy. Yeah.
Anybody else want to chime in on that?
Yeah, I think telecommunicators are just like every single one of you out there. They really, really care. They really, and like over the top, passionately care. And what Amy just said is happening no matter whether you're rural, you're sub-suburban, you're rural, anywhere. They are working a lot in a non-visual environment. And I will repeat that until we have visual, which is obviously for some of us that know this, it's not very far away, and we're not sure how we're going to manage seeing some of this stuff. But it's a non-visual environment with zero closure. A law enforcement officer goes, sees what we were told, and sees the end, maybe, or it sees it to resolution. We're on to the next call. 1,100 square miles, the whole population base. And there's sometimes very little downtime for 12 hours. My staff works 12s. A lot of people don't. They work 8s and then just double back on 16s. That's fine, right? Yeah, that's what we expect them to do. And then how do we break out of that? Is we provide them feedback. That, hey, you're doing a really good job today. I expect 100% out of my employees. 100% every day. I accept 80%. 80%, but I want 100% effort. And that's for me too. That's my admin staff. That's my QA staff. Oh wait, that's the same people. But I set that expectation, and that's for my board, because obviously I answer to somebody. They allowed me to be here today. It's setting that expectation from top to bottom and sideways and all the way around. And just giving them the power to make the decision and the praise when they do it right and a direction when they do it wrong. Not discipline. Now, I'm not saying that I haven't fired somebody. They deserved it. But I gave them all the chances. I had nothing left to give them. No more. We all had to agree we were there. So a positive environment, a positive center, and I think that's what I'm hearing Amy says. Our positive environment that we build for our centers will allow us to create positive change.
Anybody else? I'll add a couple pointers just to pull out what folks are saying. I think in the 911 centers where I've seen these types of strategies be most successful, one thing is very clear, which you have here, is that there is always a leader who is constantly like spitting the mission, reminding people what it is, walking the floor, talking to people if they have questions, asking for feedback, like really making it clear that this isn't just like, oh, I wrote a departmental policy, which oftentimes happens at 911, and it gets sent out to everyone's email, and then it's up to you to implement it, and then good luck, everyone. Like, this is a really significant change in people's day-to-day work, and like they have more tasks, they have to be paying attention to new things, asking potentially different questions. So it just takes a lot of, at all levels, reminding. And then the other thing is, and I know Amy has some examples on this too, but people need to get creative on like how you're reminding people about training. We had, we worked with the department, the 911 department in San Francisco, and they used to run quizzes during every shift on like, here are the protocols with prizes, and the prizes would, they would change depending on the shift. Apparently the nighttime shift really liked blankets, and the morning shifts like other things. Like, you have to sort of like be creative. And then one thing that we actually started this in Chicago at OEMC, and then have done in other places, this challenge of the 911 responders not knowing how the call ends or what happens is really big. I think especially right now as teams are getting used to like or the dispatchers are getting used to like, what is this? Like, what happens? So we've been doing, or running essentially newsletters within the 911 departments where the call taker who identified the call to be triaged and then the dispatcher who sent it out are like pulled out. They take a picture of them as like, you were a key like integral decision maker in the process that led to this person getting housed, or like that led to this person getting treatment or something, like a different outcome. And it's like a nice celebration that happens on a monthly basis where like you hear back some of those calls.
Nice, very nice. All right, I'm gonna have one last question and then I'll open it up to the audience. It's not a news flash that we're operating under the state law. And that's quite different from the organic way that many of your teams evolved. And so since we have the top-down legal approach to doing this, we still have to have some kind of buy-in at the local level. So any thoughts about how to organize or help local governments, local people buy into this? You know, I think, I don't know, is it better to do top-down or have it done organically? Many would argue that the organic approach, people have more buy-in immediately because they are passionate about it, as opposed to being told to do it, so to speak.
I would argue, since Cahoots I'm from the Portland, Oregon area, and that was in place when I was 10. And we still don't have a national movement with a blueprint and legs. So I would argue that I wish we didn't need top-down leadership, but apparently we do. So I think it's the right thing to do. I also think you can't legislate the expansion of hearts and minds, and that these rooms really matter. Making sure that people, especially your dispatchers, understand they are changing the world. They are on the ground level. I got to give a little, we do department awards, and I gave a little speech this year focused on Haleyville, Alabama, that first 911 call, and how obscure it was, and how, you know, sort of insignificant it probably felt to those people at the time. But that was also in the context of all of this social and civil disruption in Vietnam. You know, it was the worst casualty year. All of this chaos was going on, and you had this very significant step forward in the system. I would say Freedom House EMS is the same thing. What you all are doing right now is the same thing. And you've got to find a way to convey that to everybody around the system, that the 988 system needs to understand that, the hospitals need to understand, the jails need to understand that we are advancing a movement that is designed to thoughtfully abate these behaviors and alleviate suffering and make sure that we don't see, oh, generational cycles. This is just how it is in America. No, it's not. It does not need to be that way. And so as we connect to, I think that is universal. I never speak in those terms that everybody's not nodding around the system. I think people are fundamentally good, and that we really do want to do much better and believe that it's possible. And it does start with dispatching the right first response to the call.
Thanks. Paul, you want?
Well, just after your initial talk, I pointed and said ditto. I'd love to point and say ditto. I love what Amy said there. Yes, we were organic in putting this together. I talked about the little challenges that we had. I love what you're doing, and I love what you're doing because this is, if we leave it to organic across the country, then you're going to have different types of responses, different types of outcomes, places that never get around to doing it and come up with plenty of excuses as to why they can't, primarily money. But I think that this type of approach and what Virginia's doing is a way to create the systems, and that's exactly what 911 is, what 988 is. I love the fact that we have 988 now. This is a giant step in the right direction. We talked a little bit about the progress that's been made. We can't stop. We have to keep going. And instead of 2 states that have implemented this, hopefully we get the other 48 on board. But I love what you all are doing. I'll continue to watch from the sidelines and cheer you on.
And on that note, thank you. We have a few minutes to take any questions from the audience. Representative. Here's our Vanna White.
Hello. First and foremost, thank you so much. You all bring very different perspectives. And to the leader from Seattle, I just want to say I have loved ones in Seattle who struggle deeply with behavioral health issues, and law enforcement has been called. And so to hear you up here with your approach makes me feel really good as a human. So thank you for that leadership. I'm Lindsay. I'm a state rep from Chicago, and I do a lot of behavioral health access work. So just a basic question about public awareness. Obviously, none of this works without very strong public awareness. I can speak for Chicago. Despite all the amazing work over the years and our passage of CESSA in 2021, public awareness for alternative response models, and also despite our current mayor's big push with the care team, public awareness in the city of Chicago for alternative responses and mobile crisis and even 988 remains very low. people are constantly calling 911 for behavioral health issues. And in my corner of the city on the far northwest side, where a lot of first responders live, public awareness amongst law enforcement is really low. And when you talk about behavioral health with CPD, if we're talking about the bulk of them, they think CIT, and they don't think of this. So what are your strategies? What are the key ingredients to success that you've employed for public awareness and law enforcement awareness in your different jurisdictions?
Yeah, I just want to acknowledge that issue. The next 2 days will be at University of Chicago, with the Future of Alternative Response convening, and I've been on a tear all year. Like, we have got to simplify this and get the national message out. What happens is, first of all, social workers and clinicians tend to be very self-effacing. We don't like talking about ourselves and telling our stories of heroics. So there's that, and then it's almost hyper-intellectualized. You know, CVI work gets conflated with street medicine and first response, and we've made it so complicated that the public can't begin to understand, oh wait, we already have medics, what are they doing? We just have made it too complex. I like, again, a couple of us have referenced Eric, my husband's like, what are you saying alternative response for? Fire was never alternative police response. That's first response. You need this fourth discipline, it's community response. And so if you look at the Georgetown Center for Innovations and Community Safety, they've just published 3 white papers that look much more like the blueprint. Amy Watson is a significant contributor to all 3. One's on workforce development, one's on sustainability, and one's basically, how do we talk about this movement? So I think we need a national movement. If you think about, like, you know, love is love, right? Where you have a campaign that suddenly just permeates public awareness, rural, urban, all across the country. We need something like that. And in Seattle, my strategy, I wasn't given a public affairs team. My strategy the first year was to say yes to everything always. I probably did 200 different community forums, and I benefited from some popularity politically, that it is as popular in conservative circles, what I'm talking about, because it is supportive of law enforcement, freeing them up. It's also a very progressive idea fundamentally. And so people running for election all over the state will be talking about Seattle Care. And folks ask for endorsements, you know, from my 911 center. It's kind of weird, but that press, the free coverage, has done a lot to familiarize people. It's not nearly enough. What do you got?
So you heard me talk about the friction that existed with the nonprofits, and we could have easily just, we got the money, we have the 911, we can do this ourselves. The most important part of working together was the credibility of our nonprofits. I explained who they were and the different perspectives that they had. They were the ones on the street saying what it is. We actually created our own hotline before 988 exists, 720-913-STAR. That way phone or calls could go directly to dispatch on non-emergency. And we had folks, street medics, we had folks from Servicios, from Denver Justice Project, that would go out into the community, areas that we had need, and they would hand out that number. And then all of a sudden 988 came across. Now, again, I keep talking about the rosy finish line. We're never going to get to the finish line on this, but 911, it really took about 5 decades to implement that across the country. 988 is only a couple of years old. So I love the progress that we've made. We still have a lot more to go, but we are taking significant steps in that direction, and none greater than what the state of Illinois and Virginia are doing. So kudos to you.
Can I add one point on that,
Sure,
on
please,
public
Gabrielle.
awareness? One thing that I think happens to all government, not just in the behavioral health space, is when we think public awareness, we're like, excellent, we got town halls, we have flyers, and we're gonna do, and honestly, that's not where people are anymore. Not even on the news, unfortunately. Like, folks are on TikTok, they're on Instagram, that's where they're sort of consuming almost all information in like clips. But to point you to a good example, the Albuquerque Community Safety Department has recently launched a TikTok like push public like PSA campaign on their responses. They have someone doing like man on the street interviews, like the very popular sort of like real format where it's like, hey, what do you do when you are in a crisis? And like I'm pretty sure it's an actor. It's not an actual like person on the street, but sort of like borrowing a lot of that like narrative building that's already very popular and easy to understand in a place where people are already consuming information, I think is gonna go a really long way. And it's somewhere where I really haven't seen much like effort or investment on the side of government. And not just for behavioral health, for mostly everything.
Let's give this panel a round of applause. Amy, Phil, Gabriella, Paul. Thank you, everyone. Thank you, panelists.
When you call 988, the person picking up is going to be a real person who has real life experience and professional training on how to handle your call.
Once you're connected, we'll go through a few safety questions just to assess how you are in the moment and see how you're feeling. And then from there, we'll be able to talk about whatever is on your mind.
You need to talk, you need a resource, you need to yell, get anger out. We're there for all of it.
We respect people's confidentiality. People do not need to tell us their name or where they live or where they're at. They're in control of what they share with us.
We're not there to find out your address or something. We're there to find out about you, to explore that with you, to hear your story and what's going on. And together we can come to someplace where you can see the light that you didn't think was still there.
If you ever find yourself in a position where you don't know where to start in your search for support, whether it's for substance abuse or mental health crises, suicide, or even if you're a third-party caller who has concerns about another person, it's just a great place to start and reach out, and you certainly will never be rejected or discounted for calling.
We are not going to judge your crisis. If you say it's a crisis or you feel you're in crisis, then it's a crisis to us.
We are here to just provide support and to help you feel like you have the strength to get through what you're going through and equip you with different tools, different coping skills.
One of the last things we say is call us back. If things worsen or if you just need to touch base, we are here.
We're people just like you. We've had our dark days, we've had our good days. One thing we can all relate to is just sometimes you just need somebody to talk to and somebody that will listen.
So when you call, text, or chat, you're going to find someone that is supportive and there for you.
24 hours a day, 7 days a week, every holiday. We believe in what we're doing.
What a wonderful video and a perfect message. And before we get started, I want to remind everyone, please put your questions in Mentimeter. It will better help us to get their questions to our experts and save us time. I wanted to get started by referring to a JAMA report, a recent JAMA report. And just to be brief, it basically stated that from a period that they measured between July 2022, when the 10-digit number for the suicide hotline switched over to 988, to December 2024, there were 4,000 fewer suicides amongst young adults and children. And the report, thanks. So the report seemed to infer that it was largely due to 988, which I totally agree with, but we cannot forget that we're a part of a bigger system. So thank you to law enforcement, thank you to our elected officials, thank you to our state partners, thank you to mobile crisis teams and PSAPs. So everyone in here, give yourself a hand for that stat. Before I introduce our experts here, I wanted to just give you an overview as to what I'd like to accomplish, and I'm going to do that with a quick story. So early in 2023, I had been working with 988, and there were a few kinks between PSAPs and 988, and I was hearing all of these kinks from the 988 side, and finally I was going to go and meet with the PSAPs. So I was all riled up and I was ready to just unleash a tirade on the PSAPs like Mussolini from the balcony. But I get there and I hear from the PSAPs all of the work that they do, all of their responsibilities. And I just sat there. Instead of unleashing a tirade, I listened. I listened and I learned, because that is the only way that we could, smooth out these kinks, by listening and learning. Because I didn't know. I had no idea of all of the work that our great PSAPs are doing around the state. And I do want to thank you all. But getting to our panel, I'm going to start with Emily Grossi. She is the Marcus Alert Coordinator from the Virginia Department of Behavioral Health and Developmental Services. Next, we'll have Jasmine Dean, Director of 988 Services, Illinois Centerstone. And last but not least, Dr. Becky Day, Assistant Director of Crisis Services, DuPage County Health Department. And I'll start by asking Emily to give us a brief overview of the Marcus Alert system in Virginia.
Thank you. Thank you. I will just sit here then. Hi, everyone. It's nice to meet you. Thank you for having me be a part of this. This has been incredibly informative for myself, but then also I hope it will be helpful for you guys to learn a little bit about what we're doing in Virginia. So the Marcus Alert is Virginia's name that's based off of the Marcus David Peters Act. So in 2018, Marcus David Peters tragically lost his life while having a behavioral health crisis due to law enforcement. So they developed what is known as Marcus Alert, and it's really complex, as you guys can imagine. There's a lot of moving parts, and it doesn't always work seamlessly. I tried to make a graph, which is what I would refer to as the crisis response ecosystem. It's kind of along the lines of the crisis continuum, but at a nutshell, it's based in the sequential intercept model, and particularly intercepts 0 and 1, trying to figure out what's a way in which we can provide better responses. So we have a behavioral health system, and then we have our public safety system. And so legislatively, how can we have these two systems operate together? And I'm sure, as everyone in this room has found out, that's a lot more challenging for a number of different reasons. So would you like me to go into further detail of the exact working mechanisms for that?
Yes, please.
Okay. So we have what are known as 3 protocols in Virginia. The first one is specific for our 911 centers. So they are PSAP centers, which I think we have almost as many as you guys. I think it's like 140 something PSAP centers. And as you guys all know, if you've seen one PSAP center, you've seen one PSAP center. All 40 something of them are different. So that creates a lot of challenges. So each PSAP is required to transfer calls, but then before we even get there, each locality has to come up with their own behaviors in which they would like to classify what we refer to as Marcus Alert levels. So each Marcus Alert level gets a particular response. This is the best practice model that we have for the entire state, but it's not required for each locality to have to adopt the behaviors listed underneath each levels. We do allow for some fluidity. But so the Marcus Alert level 1 are required, 911 is required to transfer that to 988. So they have a designated phone number in which the PSAP center has contact with our 988 centers. We have 3 in Virginia, I think, and we're getting a 4th one. I believe you guys just have 1. And so then that's the introduction into the behavioral health system. There's a couple other things of like updating their CADs or updating technology, getting training, looking at what we refer to as community coverage, like how is each level going to have a response. So that's the first protocol, is just kind of the framework in which each of the locality is going to work towards. The second one is formalizing all of these agreements, so that way everyone's held accountable. There isn't anyone who can agree to something one time and then decide not to. So we require that all localities have either a memorandum of understanding or a memorandum of agreement for them to list out what they're doing in their hubs, what they're going to do within our community-based mental health facilities, which we refer to as community services boards, what fire, EMS, law enforcement, so on and so forth. The last protocol is specific for law enforcement, so they have to report their policies and their procedures, showing how they are going to take a behavioral health-led approach. So they have to share how they as the law enforcement agency, incorporate the Marcus alert levels, how are they going to try to utilize behavioral health responses, what their use of force policy is for us to review to ensure that it has verbal de-escalation or more, again, behavioral health focused approaches. We also look at, though, how are the agencies caring for their law enforcement? Do they have an officer wellness? What are they doing to produce the most equipped officers if they are going to respond, as well as also looking into CIT training commitments and a few other items. So that is the framework or the legal legislation for the Marcus alert system.
That's a fantastic overview. You know, Phil had talked about earlier about driving up from Jacksonville and dealing with the rural areas. Tell me a little bit about the challenges, with Marcus Alert from the both the rural and urban areas that you have in Virginia.
Yeah, and I appreciate that. I'm sorry, I can't see where you are, Phil, but I appreciate you sharing the challenges because it is very different. So in Virginia, actually, we have a stipulation where if a law enforcement agency serves under 40,000, they're actually not required to do protocols 2 and 3, which I think, as the chief from Denver mentioned, I apologize, I forgot your name, that creates problems because not everyone's getting the same standard of care. They also have their own needs, and simply just transferring them, like if the only requirement is just to transfer from lower level calls from 911 to 988, that leaves, probably a good amount of individuals. And then, right, the problem is, well, how can you give them resources because it comes at a cost? One thing that was passed, as soon as the budget gets signed, should be passed, this past General Assembly, was transferring to a needs-based funding approach. So those, for Marcus Alert System, so those localities that do have the higher overdose rates, the higher suicide rates, that lack insurance, lower medium income, they would, in theory, receive more funding to help boost up some of the areas in which need it the most. We haven't got to that yet, so that's tentative. But it is challenging, especially talking about the 911 and PSAP centers, because they do have a lot more roles to fill, right? If you go to Northern Virginia, they have a very sophisticated PSAP center where people are just taking calls and then giving it to dispatch, and then even in their dispatch, right, they have law enforcement pod, fire EMS pod, right? Whereas if you go to a more rural area, they're all doing the same thing. And so that trying to get them in their CAD systems up to date in the technology, that costs a lot of money. And so we do have a lot of the same issues that we're still trying to work through, I think probably as most of you. And the cultural change, getting them comfortable with wanting to transfer to 988.
That is a fantastic answer. And I want to transition to Jasmine. Jasmine's with Centerstone, our largest 988 contact center, and to give us an overview of CESSA and how it's working.
Absolutely. And so just in terms of 988 in general, you want to think about mental health and behavioral health as something that we all experience. And so you think about that across a spectrum in terms of, as we heard on the video, just having a regular day that you wake up and maybe you're experiencing grief, or someone that's calling in and they experience bullying for the first time or the second or the third time. And when you think about those situations, they can escalate to the fact where they are calling 911 and something has occurred, or that's the first number that they thought in mind to call. And so that's where that risk level and that assessment goes in, and they reach out and say, hey, well, we need you to connect with 988. And we have people that are available 24/7, ready to respond to those situations. And I think it's one of those things where when it comes to 988 and CESSA, we're just in alignment to say that we're ready to respond to all of those issues that people might be experiencing. And so when somebody's answering that call, whether it's just initiating from 988 originally or in alignment with CESSA, and that it's been a PSAP that's transferred that individual over, our goal is the same, to make sure that individual gets the right care at the right time, and if they do need some type of intervention, that's also the right thing as well. And so I'd like to say that for 988 and CESSA, that's something that we're in alignment, it's working well, and that it's always, of course, something that we continue to work towards making sure that we're improving.
That is great. I'm sure you're going to have several questions towards the end. But let me ask you right away. So if I am in crisis and I call 911, I'm transferred through CESSA to 988, what can I expect?
I think the expectation is still the same. Of course, that is a different experience for that individual. Like was stated earlier, them actually being comfortable with the fact of who they've been connected to and maybe not knowing much about 988, but that care is still going to remain the same. Once they get connected with us, we're going to humanize their experience and try to talk to them about, like, well, let's know what's going on for you today, exploring their situation. Of course, we get the information that we need from those PSAPs, and they're gracious about making sure we get that information, whether that's name, location. And so that's something that's different for us, because if somebody calls into us directly, we don't have that information most of the time. Even when you're thinking about geo-routing, that doesn't mean that we get their location. But in collaboration with our PSAPs, oftentimes we do have their name, we do have their number, and we do have their location. So we're already starting at a different space. And so we're exploring their situation, building rapport with that individual. And so we're just asking them general questions about what led you to actually reaching out today, and what do you think are the needs that are actually presenting for yourself. And they're just telling us what happened and what led to them actually calling 911. And so once we get that rapport built, then we can talk about collaborating together. What does that intervention look like? Because we're going to make sure we're assessing that individual, asking them all of the right questions, which all of our 988 professionals are trained to do. They're trained to do our risk assessment model, and they get extensive training on that. So that determines that next step. But even for that next step, collaboration with that individual is important, because they're still a human. They want to make sure that they're heard and that we are understanding of what's happened for them that day. And we're always looking for that to be the least restrictive. So starting at the bottom of that, whether that's personal supports, whether that's professional supports, and often if you've ever reached out to 988 or heard about us before, even establishing a safety plan. And that looks like a range of different resources that we can discuss and what can help you just get through today. Because we're here 24/7. So if it doesn't work for the next hour or two, you can call us back.
That's a great answer. So you talked about collecting the data and with geo-routing. Talk a little bit more about privacy and what a person in crisis can expect in regards to privacy.
Absolutely. So again, when somebody reaches out to us directly, so they're calling 988, they're able to remain anonymous. So even if I start the conversation by telling you my name and I'm happy to speak with you today and I ask you yours, you can tell me that you don't want to share that information with me. And that's perfectly fine because I'm just here to actually help you with your situation. Now, of course, if that call has been transferred to us from CESSA, like I said, we most likely have their name and their number. And so that's different, but we still start that conversation the same. Like, would you like to tell me that? They might tell us different information as well. So that's always a possibility. But in terms of that, like I said, we're making sure we establish that connection, but they are able to remain anonymous, whether that's name, location, how much information they want to share about the crisis that they're experiencing. And we make sure that we don't push that meter. Now, if it comes to a point of that we're needing intervention, we're still going to try to do that in a collaborative way. And so making sure they understand what those next steps are, what those possibilities are, and discussing them together.
Very thorough answer. So can you briefly describe what a transfer or to the mobile crisis team dispatch looks like?
Absolutely. So the goal there is for that to be a warm transfer. And warm transfer in terms of we're giving the information that we have received. And so if we do have the name of that individual, if we do have their number, if we do have their location, that's all pertinent information that mobile crisis needs to know. We want to tell them the nature of the crisis. So giving them a brief overview of what we've actually been informed of or what we've actually described as their risk level at that time. And so we're giving all of that information to mobile crisis. One, you also don't want to make sure that person has to be too repetitive too many times. If they've already been transferred, they've already told us this for the second time, they don't want to do that for the third time with mobile crisis. And so as much information as we can share as possible, it's important that we share that. And like I said, if it's going to be the fact for mobile crisis, they're intervening. That's most times that they're going to do something face-to-face. They need to know the location and who they're speaking with.
All right. I have a million other questions, but for the sake of time, I think we should move along to Dr. Becky Day, and she's going to give an overview of frequent callers to 988.
Sure. So frequent callers are those that are calling pretty regularly. We're seeing them call a couple times a month, a couple times a week, sometimes multiple times a day. And they're not, the group is really diverse. Those that are frequent callers are calling, sometimes they are having suicidal thoughts every time they call. Other times they're just having difficulty dealing with mental health or substance related issues and it's ongoing, so they continue to call. There's other times where they don't have any other supports. And as has been mentioned, because 988 is 24/7, it's very easy for individuals to reach out, right? So I could call my therapist, but I have to wait for them to call back, right? And who knows when that's going to be. But I can call 988 and somebody is there and they will answer every time I call. And so we do have a lot of very frequent callers who are calling, and it's usually just because they don't have the supports or the ability to have their needs met elsewhere. And what we've also noticed is that our frequent callers are also frequently engaging in other kind of systems, right? So they might be calling 911 a lot. They are going to the emergency department often. They might have outpatient services, but they're still reaching out to 988, which a lot of the conversation today has kind of been that coordination, but something's missing, right? We are giving them resources, we are supporting them when they call, and yet they're still calling. So it's trying to come up with an understanding of what's driving their need to call. Even though we are helping them, we're giving them resources, we're being supportive, we're linking them to outpatient services, but yet they still need to call to get supports. And so those are really the people that we're seeing call very frequently. We have some people who call 5 or 6 times a day. Other times, we know they call a couple times a month and we know who they are and we have an understanding of what they need when they call.
So what types of boundaries and parameters do you set to with these frequent callers?
So we always assess for risk, even if we know exactly who's calling and we know they always answer the risk questions the same. We always assess for risk. But then it really varies depending on what they need, right? So sometimes we have a frequent caller, for example, who has a history of trauma. And so every time he calls, he wants to talk about his trauma. The story is the same every time, and he'll call multiple times a day. And so it really is kind of helping them understand this is the role of 988. This is what we can do at 988 for you. And these are what other resources can also help you. And sometimes we have to set, like you've called 4 times, I'm going to have to wrap this up. We're not talking about anything different. It is also, follow-up is very important. So if we've provided resources, even for a frequent caller, we want to follow back up and say, hey, did you reach out to them? And can I help you? If it's, right now, if somebody was called 988 right now and we're trying to link them to a food pantry or to an outpatient, community mental health center, we could actually transfer them. We could do the call with them and help them. It's not just saying, here's a bunch of resources, go do it. And so it's understanding how we can utilize good boundaries, like call limits, call time limits if it's needed, because there are some people who will just talk and talk if we don't set those limits. But then also kind of taking the initiative to follow up and to make sure that we're checking in with them to say, did these resources work?
So you talk about these limits, but you're 24/7, and so you'll have a morning staff and an evening staff and an overnight staff. Are your counselors talking to one another to enforce these boundaries with the frequent callers?
We do. We also have a system that we use that we just kind of all of our phone calls get kind of documented so that we know who's calling. And if we've provided them with resources, we document it all there. So we have the ability to keep track of who's calling, how often they're calling, and then all of our call takers can be on the same page.
Okay. And so when you're tracking these calls, are there, what's the main identifier? Is it the name or the phone number?
It's usually the phone number, what comes up on our caller ID. We also, if the person tells us their name, then we will identify them as their name in our system so that we know that they're calling. But usually it's by phone number.
Okay. That is fantastic. So I want to open this up to the cross-panel discussion and just give a bit more information about 988 and what our experts are doing out in the field. And I want to talk a little bit about chat and text. And, Jasmine, can you talk a little bit about chat and text and how that is seemingly the preferred mode of communication for young adults and children?
Absolutely. And so when we think about chat and text, we're thinking about just how we socialize today and having a different modality that you can reach out for support. Not everyone wants to actually talk to someone on the phone or hear their voice, especially when you're in crisis. That can make someone uncomfortable. And so when you think about the different ways that you can communicate, chat and text is one of those that it makes it easier. You don't have to actually hear that other individual, but maybe you can see what they're actually typing there. And so I do find that we've seen an increase in volume for chat and text, but I think it's one of those things where it's a level of comfort. They do get the same amount of care, the same questions are asked, the same steps that would happen on a call asked. And I think when you think about being anonymous, you get that additional sense of security there, that I am just actually able to end the conversation whenever I want to. You don't feel like you're being disrespectful for hanging up the call or telling somebody you have to go. So there's a lot of different things that you can think about the reason why it seems more acceptable, it seems more preferred or more comfortable, especially when you think about being a young adult and that there's still being the stigma with mental health. I think that we've come a long way when we think about mental health, but if I think that I can just reach out and send a text message or I can actually chat and discuss what's going on for me today, it gives me an additional sense of comfort.
And Becky, can you chime in a bit about some of the challenges with chats and texts as far as the average handle time compared to the calls?
Yeah, so our average handle time is between 15 and 20 minutes for a call. For chat and text, it's an hour or more. And some of that is just because of the back and forth. People will step away, and we've said something to them, and then 5 minutes later they respond back. And so there's often a lot of delay in the back and forth. And we also don't want to just end it. We don't want to say, oh, they haven't responded in 5 minutes, I'm going to end it. So we have processes in place where we are reaching out a couple of times to kind of re-engage the person. And they can just drop off. That is, they can also text stop and the conversation ends, but it does take longer. We're also noticing higher risk on text and chat. We do, when we do need to do like active rescue, it's definitely more so on text and chat than it is through just when people call in. I don't know if maybe you have any thoughts on why that is happening, but that's what we're noticing for us, is that's definitely higher risk on text and chat.
I think it's just the level of disclosure. Like, again, going back to that comfort of what I'm willing to chat and text about, or what I'm willing to type versus what I'm willing to say out loud. And if we think about our own experiences, saying something out loud makes it more real to us. And so that being that difference there, I'm more likely to share that information with you via chat and text. And so most likely you'll see that increase in that risk level, or the likelihood for the intervention to be necessary.
I want to ask Emily, what is the state of Virginia doing for our children, the children there, and the young adults and other vulnerable populations?
Yeah, in terms of children, so we have, we just call it mobile crisis response. I know you guys refer to it as CESSA, but we have our own state-led mobile crisis response. We do have children mobile crisis response as well as adult. We also, from the DOJ settlement with Virginia, we have a program called REACH, so that is a specialized response specifically for any kind of intellectual or developmental disability. And all of this gets coordinated and facilitated through our regional hubs, which is connected to our 988 contact centers. So we do have a variety of different services that can be dispatched if a child or someone with an intellectual or developmental disability is requesting it. Obviously, it gets a little bit more challenging if it is if they lack capacity, or if it's at a heightened behavior or situation. How we have worked to what we call our gray areas, how we've worked is that we do have a lot of either co-response or alternative responses, kind of like the Cahoots model, throughout the state of Virginia as well, to help fill in some of those gaps.
So does the state of Virginia, are you participants in the chat and text area?
Yes, yeah, we do. Okay. Yeah, and it's the same, right? We do allow for, as what was mentioned up here, chat and text. The risk is higher, and it is probably close to the same in terms of call volume. But a lot of our citizens also prefer call or texting instead of calling.
So I heard that, from the panel, that the average handle time can be much longer, and the severity of some of these can be much higher. With the increase in chats and texts, as Jasmine stated, what are some of the things that we can do or we're looking to do in the future to address the chats and texts that are coming in?
I think for that, you just have to rely on making sure that the training is there. And like I stated earlier, our 988 professionals, they're trained in overall risk assessment, and that isn't something that changes based on the modality. So you want to make sure that they're still getting the appropriate level of care regardless. But even in those situations, for the professionals that are actually offering those support to those individuals, you want to make sure that they're getting support as well. So that's something that we rely on within Centerzone, is making sure that our staff members, we value their self-care, we value their need for supervision, we value their need for additional training and support. And that's something that you want to be continual, not something that just happens at the beginning of the start of your position, but as you continue, as things change, as the world changes. And so just relying on the training that you've had, knowing that you have people within the network to reach out to for additional support. And I think as long as that continues, as long as those conversations continue, that that we'll be able to navigate the chat and text space.
That's a great answer. And sticking with you, Jasmine, with Centerstone being the statewide backup, your referral network is statewide. Can you talk a little bit about the different referrals between urban, rural, suburban?
Absolutely. So, of course, that is a very large range. And so we like to make sure that our resource database is up to date, whether that's for the fact that we have everything that is listed, whether you're thinking about social determinants of health, you're thinking about food, you're thinking about housing, whether that is that we need the information for mobile crisis and the PSAPs that are in the area. And things change all the time. So making sure that is something that is up to date. We review those resources. We add them as needed. But when you think about that being from somewhere that might not have the resources that are local, or that being a desert of sorts for the resources that are available, sometimes you might not be able to find them something that is local in nature, but you're talking about something that's national and helping them get connected. Whether that ends up being that we close the loop by returning back to 988 for support, because we have to think about professional supports, but we also talk about personal supports. So when you're thinking about creating that safety plan, it might be the fact that it's not indeed a resource or a referral, but what do you naturally have within your own environment that can support you with the situation? And so when we talk to individuals, we like to think about that at a large magnitude of what do you naturally have versus what are some additional things that we can provide and assist you with.
Okay, I can listen to these experts all day. I think I have one last question, Emily, and you know, with the state of Virginia and the state of Illinois, we're implementing similar programs, and I think it benefits us to talk. There's a lot to learn from both ways. What are some of the lessons learned in Virginia that you'd like to share with Illinois?
We're still learning. And I say that in a joking manner, but in all honesty, it's often said in Virginia that Marcus Alert was flying a plane while building it, and I don't think that couldn't describe the issue even more. I think the collaborations and the connections, right? Like, I was really happy the panel before they talked about whether it was, you know, legislatively being mandated versus organic, right? Pros and cons to both. And so if it is legislatively mandated, how can you still have that collaboration and buy-in, which is really challenging? And training from the very beginning, and training even more so of not so much how do these systems work, but what are your roles? Because we're now asking public safety to step into behavioral health in some way, right? And not that they hadn't already been doing that before, but a little bit more so acknowledgement of that role. And we also have to have our behavioral health step into public safety at times, especially because Virginia, we're really big on co-response or some kind of alternative response. Even our law enforcement or public safety would like, even if it's just a mobile crisis, to have some public safety awareness, right? So understanding roles, understanding a little bit of everyone's profession in a more in-depth way than we had. Connection is key. And technology, as I'm sure everyone's all mentioned, right? Like, how is there a way to have all of these systems be able to connect and communicate as much as possible? I think those are our biggest takeaways in some of what we've learned, yeah.
Okay, that is a great answer. And I'd like to leave a few minutes for the audience to ask questions.
Hi, good morning. Thank you to the panel for the incredible insight that you've offered, and also thank you to the panel that came previously. I'm still thinking about the mention from the first panel with regard to the system by which they categorize the behavioral health needs of the incoming calls and the proportion that was related to substance misuse. And I hope I hope that I'm summarizing that appropriately. So I wonder if you can speak to how you make any special considerations for people that are calling in who you either believe are under the influence, and so that's part A. And then part B is similar. related to the special needs of individuals who are in the midst of a maternal mental health crisis, if you're asking them if they're expecting or postpartum, and how you make special considerations for those individuals. Thank you for the work that you're all doing.
And so to answer your first question, when we're thinking about substance misuse, I think when we're talking about training, that also includes exploring the situation. And so that's something that we heavily train on so that they can understand what are the questions to ask, but when is it the opportunity to listen and ask for more, and try to gather more information. And so in those moments, you have to make sure that somebody feels comfortable sharing that information with you so you do know what the necessary next steps are, because as I stated, we also want to make sure that it's least restrictive. We don't want to put them in a situation where it does cause them any sort of harm. So at what point does the intervention actually need our additional resources that are within the area? And so it's gathering the correct information, whether that is substance misuse, whether that's maternal health, asking the right questions, getting that information, and then collaborating on what is the next step. What did you need from me here? Whether that was, did I need a resource? Did I need something that was regarding harm reduction? Did I just need a safe space to vent? Because even though that is the topic that's at hand, it doesn't acknowledge what they needed in that exact moment, if that makes sense. So making sure that you collaborate with that individual on those concerns, whether that's substance misuse, whether that's maternal mental health, and somebody needing support, whether that's for their child, where they're expecting, that you're allowing them the opportunity to share with you exactly what they need in the situation that is unique for them.
I can share a little for Virginia. A lot of what was already mentioned. I think the one thing that we do that the previous panel also recommended as well is for our mobile crisis that responds similar to your guys' program, it's not included. But in the localities where we have some kind of alternative response or co-response, we're very big on peers, right? So not only the additional training, but I don't know of many teams that don't have a peer for that support. And I know peers aren't typically seen as a source for maternal or postpartum, but it is very heavy for substance use. In addition to the training, though, that is something that is taken into consideration when the locality is determining, okay, what are the behaviors or what are the issues or needs that we're going to use to categorize each of the levels, because the levels determine the type of preferred or, first utilized response as well.
Hi. Thank you guys for doing this. My question for Virginia and for Centerstone is for about third-party callers. So typically someone third party sees someone outside, sees someone that they believe is having some sort of crisis or behavioral health thing, and 911 would typically send someone to go check on that person. What is the criteria for you guys to send an MCRT to a third-party caller's request for this person to be checked on?
So for Virginia, which I would imagine is probably going to be very similar, if the individual who is needing the service does not have the capacity to consent for said service, then that is not an appropriate, we don't allow for that. Where we do have alternatives is, again, where we are really kind of making a robust effort to have as many alternative, I think we're, up to almost 30 teams of some form of like co-response or alternative response teams throughout the entire state of Virginia, with easily 10 more coming on this fiscal year, right? So that's where we're addressing those third-party calls, is by having an alternative response to our mobile crisis team.
Okay. And we are at time. I'd like to encourage everyone to put any further questions into Mentimeter, and we will address those as well as we can today. Oh, I'm sorry. Jasmine's gonna respond.
Absolutely. So I was going to say likewise to the same. I think that each situation is different, so it's hard to group them together. But when you're thinking about third-party interactions, whether that's somebody that's known or unknown to the individual, it still can be a third-party situation. Our risk assessment and our information that we're trying to gather is the same. So it really depends on, do you actually know that person's name, their location, and what that risk level is? Do you know if they've attempted to cause themselves harm today? And so if that's information that we can obtain, that makes the situation different versus the fact of if we're trying to cold send a response to someone that hasn't reached out or given us any information. That's a situation where if we are speaking with a PSAP, maybe we're telling them like, this isn't appropriate for us to actually send this resource. Can we collaborate on what that next step is? And I think the biggest part is collaboration based on the information we obtain.
Thank you to our experts, and we are going to transition immediately to our next panel.
Mental health is just as important as physical health. They go hand in hand.
We operate within the community to provide mental health care.
We help get people connected to different services so that they can hopefully start leading a productive life.
Our mobile crisis team is made up of master's level clinicians who have social work and therapy backgrounds, as well as peer support specialists. And essentially what they do is assess mental health emergencies and crises in the Hamilton County area.
So as a clinician, I respond out to different places, whether it's homes, schools, out in the community, for crisis de-escalation, or determine if they need to go to the hospital for more psychiatric evaluation. This is the patient at their most vulnerable time, so I want them to know I'm not here to judge you. I just want to make sure that you're safe and you get the help that you need.
I love going out in the community and meeting people where they're at, especially when they're in the middle of crisis, because they don't realize the amount of help that is available to them. A peer support specialist is somebody who has lived experience with either mental health issues or substance use disorders, and we use our lived experience to help other people realize that potential for themselves, and that we've got an entire community that's willing to jump in and help get them on the right track.
Back in 2022, Mobile Crisis received expansion American Rescue Plan Act funding from the Hamilton County Commissioners. And with those funds, we've been able to expand our program to 24 hours, 7 days a week. We've been able to embed much more closely with local law enforcement and 911. Most importantly, we've been able to provide education to our community.
I always find myself wanting to do better so I can be better for other people and help them in the community.
That's what I'm here for. If nothing else, we get to plant a seed and hopefully plant it deep and water it well.
Good morning. Let me introduce myself first before I introduce my esteemed colleagues. I'm Brenda Hampton. I work with the UIC Crisis Hub. I work with the community mobile crisis response teams primarily. How many mobile crisis response teams are represented in the audience? These are the boots on the ground people. Crisis services is not easy. The work that staff do, the work that they perform to save lives, to intervene in lives, to make sure that crises are resolved is incredible. And so I want to introduce my colleagues who are part of the crisis system. Their resumes are in the QR code, so I'm not going to go through their resumes, their bios, but Angela Catalino is the Director of Crisis Services, Mobile Crisis Response Teams at LifeLinks Mental Health. Janique Dean, Dr. Dean, is the Clinical Director of Crisis Services for Trilogy Behavioral Health Care of Chicago. Amanda Stamps, Masters of Education, is with senior leadership with Community Bridges, Mobile Crisis Response Team in Arizona. And Leanne Huff, Master of Education, is with the Utah Department of Health and Crisis Administration and Human Services, Office of Substance Use and Mental Health. So I just want to start off with the theme of this panel. Mobile crisis response teams in action, improving outcomes for individuals and communities. I'd like each of my colleagues to give about 2 minutes of what they do in mobile crisis response team services with their respective agencies or organizations. Amanda.
Good morning, everybody. What we do at Community Bridges, I'm the Senior Director over Regional Operations. We actually have teams in 3 states, Arizona, Idaho, and Oklahoma, and it runs a very wide variety of super rural to very urban. So we, regardless of where we are, our main message with our teams is anyone, anywhere, anytime. We wholeheartedly believe that. We do everything we can to run 24/7, 365, no matter where we are. And from an operational standpoint, it's hard. But we successfully have kind of found a way to do it. In addition to what we do when my people go out into the field is we have a very intense follow-up process after the fact. The chief was talking about what do we do after the call. And all of my teams have clinical oversight and are very embedded into a continuum of care. I am very lucky that I live in a state that has a very robust crisis system and continuum of care. But in our rural areas, that's not always the case. So my individuals have to do a lot to get people established with services and to keep them that way. And I think those 2 things kind of are what my company really pushes when it comes to mobile crisis response.
Dr. Dean?
So I'm from Trilogy. We are located on the north side of Chicago. Our crisis teams cover that area as well as some suburban Cook, Evanston, and Skokie. We are 24/7. We have about 18 staff in the program. Our mobile crisis response team consists of a peer engagement specialist, which is an individual lived experience, as well as a trained mental health clinician. In 2025, we responded to about 5,000 calls, of which 38% of those calls came in, 38% of those calls came in as self-referrals, and 19% were family referrals. The top reason for the call was depression, which came in at about 54%. And yeah, that's what we do.
Ms. Huff?
I work for, as stated, for the Office of Substance Use and Mental Health, and I specifically see in my role, I'm on the crisis team as a crisis administrator, and I oversee the mobile crisis teams for the state, as well as civil commitment training and CIT crisis intervention team contract. And the way our state works is, funds pass through our office and they go through to the 13 local mental health authorities that serve community mental health in the state. And so those 13 local mental health authorities cover 29 counties. And every local authority has a mobile crisis outreach team that can access each part of the county. And in our statute and rule, the teams are a 2-team mental health response of a licensed clinician and a peer support specialist. So that is what we strive for in best practice and monitor to. However, because of staff challenges, we do have to be flexible with some of the rural areas as far as getting those teams to that level. And it is a 24/7 response.
Thank you. And Angela?
Well, I'm Angela, so most of you that just raised your hand, I do what you do. So the boots on the ground. I come from rural America. Our biggest biggest coverage area is in Mattoon, which is our central location. So we're about 17,000 people. Our coverage area for our region from one end to the other is 2.5 hours. So you could imagine that if we are on one side and we get called to the other, we panic a little bit. We do have a team of about 18 right now. That's our top number for rural. For being so rural, our numbers are high. and I only have this number in my head because I just reported it, but for quarter 3, so January 1st through March 31st, we had 1,253 calls. That is a mixture of just your traditional true crisis calls that you get on our hotline that we have. And it was a little over about 550 for actually going out into the community. We have 3 hospitals in our area, 2 are extremely rural, and 1 we have that we get the majority of our calls. Very rarely do we go for 1. We get called for 1, we leave seeing 4. It's kind of like the community knows, ooh, Lifelinks is going to the hospital. I better hurry up and go there while someone's there. So a lot of what I have to do in the community, because we are rural, is more of the, I think, Phil, you said it a lot earlier, that collaboration. You have to get out there, you have to communicate, you have to collaborate with your local people and your agencies. I have constant meetings with schools, with the police, all of the things, all of the people. We have to do a little bit more because our resources are less. We are a resource desert, so we struggle with a lot. We don't have everything on every corner. We may have one of each of everything. And as a lot of people have, especially in rural America, we are low income. So the clients that we have don't have the opportunity to drive 45 minutes to go to therapy or for whatever it is that they need. So that's kind of how we work in rural America, and I'm glad to be here today.
Thank you, Angela. So for each of you, what would you say are the 2 most critical factors that impact a successful alternative crisis response approach? Starting with you.
I have to go first every time. I think one of the biggest factors for these teams is the availability of 24/7, 365. When you look at workforces, especially in rural areas, and there was a mention of being able to how we staff these. My teams are not traditionally staffed. I use BHT levels with peer, with clinical oversight on each call, so my clinician's not in the vehicle. I run 15 different teams, and I have a staff of about 6 clinical oversight licensed people that are on call and do, in fact, work every call with my team. So we had to get a little creative in how we did the clinical oversight because, quite frankly, in the workforce, there's not as many people out there. The second part is really that first responder law enforcement relationship. All of our crisis systems that we currently work in luckily have CIT-driven agencies. So we fit into CIT pretty well in the majority of the areas that we work in. And that's really important because we speak different languages from law enforcement to behavioral health. I'm 25 years retired law enforcement, so I still know the secret handshake and they'll talk to me, but it does help to have those constant ongoing relationships with law enforcement. So I think those are really the 2 factors in creating that successful community response program.
Dr. Dean.
I would say for us, it has been caring for the people that are doing the work as well as cultivating the ecosystem of folks around it. So this was building partnerships, creating relationships in the community, attending community outreach events. For 2025, I know Trilogy participated in 98 community outreach events. And as far as the staff, it's all about culture and trying to prevent burnout. For this current fiscal year, I know we're not finished with it yet, but we currently have a turnover rate for our mobile crisis response team of 17%. So I think we're doing pretty well. But we have really emphasized like staff empowerment and a staff-focused environment.
Those are all really great points and important. One thing I think of, we just had our own crisis conference, but when I think of something, because all of that goes into a successful outcome, but being able to engage, and that's where I really value peer support, as well as a good clinician, but peer supports offer so much in being able to connect at sometimes levels that maybe I wouldn't be able to, depending on my experience. So having the ability to have peer peer support on the teams, I think leads to really great outcomes. I like what you said about taking care of your staff. Another thing with staff challenges is we're really trying to educate the local authorities that crisis work is it's a niche job. It takes a certain person to do that work, and it's, you know, we're asking mobile teams to go into unpredictable environments, so it is more stressful, and so we're trying to you know, get them to have a differential pay for them, a different pay system, because I do think that will go a long way to attract individuals into doing mobile crisis outreach.
I think for us in the rural areas, I said it once already, is that collaboration that you have to have with everyone in the community. And I think another aspect would just be creativity. You have to think outside of the box in rural America, unfortunately. Everywhere that we go is 2-lane highways. We don't have, you know, this and that, and you can turn down this street and then turn here to get it. That doesn't exist in our area. So a lot of the times when we're going to those calls, we have to think about, okay, what are we going to do? What's next? If this doesn't happen, what's next? So my team is always, while they're in the car driving to those areas, is thinking of, okay, if this doesn't happen, what are we going to do next? I've said this on calls before, but with the weather changing, as everyone else has, you know, unique aspects what they do, right now, we're fighting the tractors on the road. You know, in those 2-lane highways, those tractors take up the whole road. So when you're going to someone that's suicidal, you get more anxious. So then it goes to, with your staff, when they get back from that, debriefing and talking with them and, you know, boosting the morale and doing those activities to boost that morale. We just did one with my team not too long ago, and they had a blast doing it. So we just really think outside of the box a lot.
Relationships. We've heard relationship building a lot. But for our partners now who are EMS, law enforcement, and PSAPs, how do you assure them comfort and confidence in the experience of your staff to address local community crises? I'll just open it up.
I think that is obviously really important, and it's been a topic in Utah in our meetings that we have. One, because the challenges with civil commitment and transportation and all that. So we do have a standardized training we created in Utah that every crisis worker has to go through this training to get 40 hours of basic knowledge before they start working in the field. We did that because when we surveyed all the different local authorities, they all had a 24-hour crisis response, but the crisis, it was very different. It was different across each local authority. So we were trying to provide some consistency that will help that individual be stronger and work with the community partners. But I do think, yes, we talk a lot about relationships, and I think that's key. The foundation is building those relationships with your first responders, because that in itself will increase trust. But also having crisis teams that their only responsibility is to respond over and over to crisis, because that does make them the expert. And I say that because there are some areas that are using their outpatient therapists on call, and they're doing that because they're rural areas, but I do know that lends to not the same confidence when you're going out in the community.
For me, it's just going into those meetings. A lot of the times I have to wiggle my way in and push my way into meetings with different people. We at my agency, we do have a crisis walk-in center. It's very similar to the living room, but we're just funded different for it. But I invited all of my local law enforcement, EMS, fire department. We had a meeting at our crisis walk-in center so that they can see it. This is what we have to offer in our community. This is what we can use instead of the ER. And I tell them too, you know, if you have other officers that couldn't come to this that want to see it, just shoot me a text. And if I'm there, I will meet them at the door. I will give them a tour. So I do that quite a bit, and I go into the schools a lot just so that they are aware of everything. I bring candy and donuts and stuff when I can, so usually they'll let me in.
I think definitely building relationships and maintaining them. We have a pretty good relationship with Evanston Police Department, as well as Sergeant Estrada and his team in the back. But we meet monthly. We talk through calls that we went on together. We process what we maybe could do different or how we can support one another. And we continue those conversations in hopes that we can have more clarity about what to do when we respond on the scenes together, in hopes that we get somewhere.
I think the biggest thing is just to realize that we both have functions and they look different, and that's okay. I think way too long there was this attempt to make it a crossover function, and I'm not saying that that's wrong. Sometimes that fits in some areas, but we have to hear each other's point of view. I will never forget the moment of clarity that we all had when we were discussing about sending out these teams and going out without law enforcement. And the provider who did the 988 services, it wasn't 988 yet, but the one that did the call center looked at us and all the law enforcement people and said, maybe you should ask us what we're comfortable going on instead of telling us what we're comfortable going on. And that was a huge light bulb moment for us. And we really pushed forward after that. So I think being able to speak to each other about police culture training, that's very important. Going out there saying, hey, this is why law enforcement, EMS, fire, this is why they do what they do. And vice versa from the behavioral health side, just having those conversations and realizing that we actually can be kind of different and work together and it still works out. But being allowed to have each side say what works for them is really important.
We've heard a lot about safety and the concerns about responding to crisis with the unknown. What do you tell your staff, and what would you tell the audience? How do you approach that topic of safety for mobile crisis response teams?
I tell my staff all the time, if you have that ick, trust that ick, because that's when something will go wrong. And because I have such a good relationship with law enforcement, they know that they will come at any moment. Obviously, we all have the things set in place, the questions that you ask before you go and all of that. And my team at my agency, we have a special app that we use called Forewarn, where we can look clients up and see if they have battery charges. If there's 5 battery charges within the last 6 months, we are not going alone. It doesn't matter if we have that team approach or not. We are going to have police come with us. So I always tell them, trust your instinct.
For us, it has been, it has been being intentional from the beginning, like when you're interviewing. I think crisis has finally begun its own lane. And oftentimes what I've heard is, you know, I used to be a therapist, so I know I can do crisis work. I've worked in child welfare, so I've mitigated crisis many, many times in my career. But the work in mobile crisis response is very different. And I think making that speakable in the interview and being very intentional about this being the nature of the job before people sign up for it. But we have also implemented processes and procedures throughout our staff's experience that have come up. So one of those things was like a code word. So when our staff are on scene together, because they are a team, just making sure they're both on the same page. I would tell you the code word, but I should not. But there is a code word where they both know, like, it's time to exit immediately and get back to the van. We invested in the Palm devices and also working with them to get the app, which I believe will be used more with today's workforce. We also had implemented a crisis triage assessment that we do when we answer the phone, just to make sure that we can get as much information as possible. Of course, we won't have it all, but it does help going in. And then there has also been just intentional conversations amongst the team. We have a safe committee that are staff on the ground doing the work that come to us in leadership and talk to us about their experience, keep us informed on things that they're seeing. And that conversation then helps us as leadership redesign policies and procedures to support them.
Just follow up a little bit on what you said. I think where it starts for us is requiring experience for crisis mobile teams. We do not take anybody that doesn't have experience. I do not think that's a place to start your life as a crisis worker. We are privileged that we have enough in our states to satisfy that, but just having that experience and understanding crisis is really so important. And honestly, with a peer-driven model, they are less likely to be uncomfortable. In fact, some of my peer individuals, I have to pull them back. I have to rein them in because of their lived experiences. They really are, sometimes, in my opinion, a little too comfortable, and I have to make sure they're still following our policies and procedures. But the training is really important, you know, getting weeks worth of training before they're even making their first contact, to include situational awareness and safety training, and how does that look? And from an organization to say, obviously our preference is if law enforcement is not involved, that they're not involved. But if they need to be involved, we support that too. I have seen some organizations that push it so hard that the staff hears that as never call 911, and we have to empower our people to make those decisions when they go out there. And if we see a pattern, then we talk to them about that specifically and see how we can work with them to improve their level of comfort if it's too much. My teams on average use PD less than 10% of the calls, and that's about, in the state of Arizona, we run 17,000 calls. So it's very rarely that we engage it, but I know when they do, there's a reason, and that's okay. And we make sure that the messaging is there. If you need it, please use it.
So messaging, how do you get the word out to your community, the service areas that you're responsible for, about what it is that you do? We know at the state level, at another level, there may be those messages, but what do you do, again, boots on the ground, to communicate the resource that you provide to the community? Leanne, I'll start with you.
Yeah, in addition to the state level, the local authorities are encouraged, and many of them do. They attend community meetings, and when they're not on a call, we encourage them to drop into the library, drop by the police department, the fire department, just to educate. Because as mentioned earlier, people do forget. We've had mobile crisis in Salt Lake County since 2011, and about 6 months ago, someone was mentioning that a Sandy police officer didn't know that MCOT existed, and I shouldn't have been shocked, but I kind of was, and it just really speaks to the importance of those regular maintaining relationships with communities, so that you come to the top of their head when there's something happening.
I would say, I think someone said it earlier, as far as staying relevant in social media today. We have a development team, marketing and development team, that helps us make sure our outcomes are being posted and people understand the work that we're doing and where we're located. We also, again, attend a lot of community outreach events, and we've gotten to the point where we're thinking more outside of the box. So we are at farmers markets. We did a Halloween trunk or treat, but again, wanting to appeal to the younger population, but also just thinking outside of the box of where maybe some of that community outreach may lack. Myself, I'm also a regional committee member for Regions 10 and 11 for CESSA, and we make a lot of attempts to participate in work groups that come across our tables throughout Illinois, and so a lot of it is, again, maintaining those relationships with other folks in the community so that they can also tell their clients and their staff about us. And we also facilitate trainings to local organizations to tell them more about mobile crisis response work.
What are the challenges? What are the challenges? What are the barriers that you have experienced in providing mobile crisis response team services?
I think for us, like I've already said, is just being rural. getting there in a timely manner. Because even staying within our town of Mattoon, from where our agency is located to the farthest point, which seems close, it's maybe 5 miles, but it's rural America again. So just getting there in a timely manner and getting there fast enough. Because I think everyone here probably feels that. We feel like we can't get there fast enough. We're not the police. We don't get to put that red, light on the top of our car, and we have to do the speed limit.
Yeah, as I think about that, I'm thinking about the challenges of response time, not only in rural areas, but for first responders, because we know that if you don't get there quick enough, they're going to make the decision on their own. And if they have one bad experience, chances are they're not going to call you out again. So for us, that is a huge focus on how can we strengthen those relationships so that law enforcement will utilize MCOT as well as 988, because in the data we collect, we do have public-facing dashboards of each local authority and all our quality indicators, and then we had some technical assistance, and what they found in the focus groups is law enforcement doesn't really understand 988 and how it can help them. So right now we just have a really big focus on how we can improve those relationships, build trust, respond in a way that they're going to want to use our mobile teams in 988.
I would say for us, it has been, again, creating workflows when we arrive on scene with CPD or Evanston Police Department, Chicago CARE, just having some clarity on who's doing what and when, but also including when we are transporting to emergency rooms. The respect just isn't there yet. And so oftentimes, we may go ahead and transport and you arrive at the emergency room and then you're met with more resistance. And so that can be frustrating for our staff. In addition, many of you have heard me say this before, but parking on the north side of Chicago is a problem. And so I remember reviewing our data and seeing that addresses that were right around the corner, the response time was pretty significant. And I remember thinking, what are our staff doing? Are they getting out on time? What is happening? And the more and more I looked into it, we found that our staff are circling the block and, waiting for a park to open because it's a snow route, or it is residential parking only, or overnight there isn't a park. And there's tow trucks out that are threatening to tow, or they come out to that orange ticket that's on the vehicle. And so it has really been an issue for us to get in a timely manner. And so that absolutely continues to be a challenge. And lastly, I would probably say just having dedicated training pathways that all of our staff are doing, and with more of looking into certifications or some level of training that allows things to be more uniform for our staff and for other mobile crisis response teams.
And I would say my biggest challenge is keeping somebody available all the time and managing how many calls they go on and sleep at the same time. With funding, we all tend to run a pretty lean model in order to get enough people out there. But if I have a team of 8 that is supposed to cover 24/7 and somebody takes a day off, I no longer have 2-person teams. So you're constantly juggling your staff and begging and pleading and trying not to burn out your staff or your budget. Because there's just not extra people hanging around waiting to go take a call. So I think with the models that we're using and the funding that we have, everybody's doing an amazing job as best as we can, but it would be nice to be able to address some of that overlap and realize that, yes, in fact, you can work somebody for a 12-hour shift and they can be on call for 12 hours. That's amazing, until the days come when they're on a 12-hour shift, they're on call for 12 hours, and they end up coming in for 10 of them. I don't know about you guys, but I am too old to be up all night anymore. So I think that is probably one of our biggest challenges, especially in our rural areas, because you kind of roll the dice on what the numbers are going to look like, and you formulate your staffing year after year, but you're based on the prior year's numbers, which might change for the next year because everybody's doing such a great job of getting it out there now. So I think just that constant balance of having people available, always being available, but budgeting it, and then your staff burnout rates, managing those constantly, because you will end up losing people after a while because they just can't do it anymore.
So last question. Is there one skill or technique that your staff use to have a successful outcome? What would that be?
Patience, because we are seeing people at their worst. So we have to give them time and give them the space to get it all out, I guess we'll say. So that would be my answer.
I don't think there is one. I think there is definitely a combination of, building rapport and de-escalating, providing emotional support, active listening, being able to safety plan. But then it changes a little bit if there's, for example, family on the scene, where we switch into more psychoeducation and providing emotional support for the parents, or, whatever the relationship may be. I think, and oftentimes if, larger community systems are involved, and it's about, being able to coordinate those systems. So it really just depends on what is happening in the moment.
And yeah,
sorry.
Yeah, as I'm hearing, they're also important patients, and one thing we emphasize a lot on is just being a better listener. I think we take it for granted, and as humans, we want to rush into fixing the problem. So really, in our training, a lot of the stuff we do, we emphasize a ton on just engagement, and taking that time to really connect, and then hopefully be able to de-escalate. The opposite.
And I would just say that human connection and making sure that your policies, procedures, and the way we do things doesn't override that. I've seen that happen a little bit, especially on our bigger teams. They're churning a lot of numbers. That yes, we're going to go out, we're going to do our assessments, all of our assessments are clinical, but to make it still have a connection, even though they're doing these clinical assessments, I think that's why they are successful. I think that's why these teams are pretty much the thing we need in all of our areas to get people the help they need, is just remembering that connection, even over policies and procedures sometimes.
Ladies, thank you so much. Let me open it up for questions. Let me open it up for questions, one or two. Yes.
Speaking of old, let me run over here.
I guess my question is more operational. How do you guys get notified to go out, each of you? And do any of you guys have radio contact with police or fire, like an actual portable with you? And if you don't, what is your oh crap button? Is it just call 911, or do you guys have, I've heard people have apps to immediately notify the PSAP that you need law enforcement. So what are those things for you guys?
Our calls come in directly, most of them come in directly from the community, but we also receive calls through 988. We may get some calls from police on scene as well. Unfortunately, there isn't a button that we're able to press, but because we do have a team model, there is an opportunity for someone to step back or step away for a moment to be able to call 911.
15 of my 16 teams run through a 988 version. I have one that gets direct calls from law enforcement and school districts. That one we triage everything ourselves, so everything else gets triaged through a system. We do have a button, but all the button does is call 911. So it's not like it's a fancy button like in law enforcement. It's faster. It's one button instead of 3 buttons, I guess. All of our teams are tracked by GPS. Their phones are tracked. Their vehicles are tracked. So we always know where they are. Our super rural areas, we actually even have some frontier teams have satellite phones, so they always have access to connections somewhere, no matter where they are. So yeah, that we're doing the best we can. I wish there was a magic button, but we don't have that yet. And none of our teams run with a radio with law enforcement. Very few law enforcement agencies would love that.
Yes, hello. I'm curious to understand if you could speak a little bit about follow-ups. So, for example, maybe making referrals to other providers, you know, once your wonderful teams have been out there to meet with folks.
So what my team does right now is we do a 24 to 48 hour follow-up no matter what, whether they're hospitalized, whether they're deflected, no matter what. Even if we have a canceled screen, we still do follow-up. All of my team has the information for all of our local community agencies. There are not many, so they probably have them memorized. But they know that they can refer there, whether they call themselves or they do it right then and there with the client that they're with, or if they want, they just give them the information. But coming up here soon, we're going to be doing 3-day follow-ups. So we'll be adding on a little bit more coverage for that, which in the end, I think is really good.
In Utah, follow-up is part of one of our indicators that we collect that data, but what we've learned is very different across each local authority. So some of the communities are doing 12-week follow-ups, some are just doing a single follow-up to make sure that they connected with the person and they were able to connect to resources. So we're working on trying to standardize what that looks like now, but we see it very different across the whole state.
We are following up for 72 hours currently. On occasion, if there's a unique situation, we will maintain the client for a longer period of time, usually about up to 30 days if need be. And when someone is hospitalized, we maintain connection with the hospital staff, and when they're discharged, we start their 3-day follow-up from there.
All of my contracts require 24 and 72-hour follow-ups. They're actually written into the contract, which is helpful. And even if they go to a higher level of care, we still try to follow that protocol as much as possible. Because I have 100-something staff, we split it up to the teams that are between shifts. So they will do a lot of the follow-ups for us, so the teams are always available. In our rural areas, most of the people know each other. They're part of the communities, so they can be pretty involved in their follow-ups after the fact because they know the providers and the individuals pretty well. My company is an integrated behavioral health company, so we have internal referrals, but we also utilize, if they have a behavioral health home or an FQHC or any of those, we refer out to whatever is appropriate to their level of care.
Okay, any other one question? Over here.
I wanted to say that there's a lot more awareness about mental health and a lot more awareness about mobile crisis, but you're still dealing with urban areas and rural areas where there may be stigma surrounding mental health. So I was just curious if you guys wanted to share any experience. Let's say if you have to go out to see an adolescent that may require inpatient hospitalization and you have a parent that's not willing. How do you engage with the communities to address stigma?
I'll take that. I think running a peer model is very helpful in addressing stigma because a lot of times the parents, the families can see individuals that they trust and relate to. So I personally, especially based on my prior experience, I know that if there is that connection and they see themselves and the people responding, that there's going to be more likely to develop that trust in response. And the more that your teams are out there and the communities get to know them by attending the community events and just being a little more forward, it helps alleviate that because it's not, the stigma's there, right? We all know it's there, but when you start developing the connection and that person's face is familiar, or I know them, or they've lived similar experiences to myself, I really think that helps manage some of those issues with stigma.
That's where I was going to go to. That's where I was going to go to with the peer. While the clinician is kind of talking with the client or the child that you're seeing, the peer can talk with the family and kind of go over different aspects of it. And just, I mean, the stigma is not going to go away. It's never going to go away. It's always going to be there. So it's just all about education to people, whether it's with a flyer that you have, whether it's with a training, whether it's a website that you can send them to where they can learn more about what we're doing.
So yeah, especially in the rural areas for people, because it was brought up that they know you, they might know each other, and so that does create a lot of challenges where maybe they don't want you coming to their home. Those are just challenges that the rural areas are always having to work with. In the urban area, I mean, so one way we address it is just having unmarked cars, right? And not advertising that you're a mobile crisis unit so that you're coming in discreetly. And that is important because we know as neighbors, when the police come to your neighbor's house, we're all wondering why that's happening, right? So we do a lot to try to just make the actual outreach as quiet as possible.
I agree with everything that everyone said. One of the other things that we've been doing is more recently we went to in Evanston High School and did a training with a youth council. And part of that was educating on the stigma, educating about mobile crisis response services, because we also figure if we get in front of some of the young folks and do some educating, they may be also able to spread the word around.
So let me again thank the state of Utah and the state of Arizona for allowing two of our presenters to be here. And let me thank two of our mobile crisis response team project directors. Ladies, thank you.
Okay, it's logistics guy back again. First of all, I want to say thank you to all of you live streamers. Apparently, there are almost as many of you online as are in the room. We're really glad that you are with us. And thanks to everybody who has been watching a recorded version, talking to future self. This is going to be the end of the live stream. And so we're going to shift into here for lunch. Now, I want to apologize to Table 1 because we kind of realized you guys have not had a great look here. So the prize for that, or the compensation for that, is that you and Table 2 will be first tables that are going to go to lunch. So let me tell you how we're going to do this, if you don't mind accommodating. Certainly, everybody can stretch kind of where you are. And, you know, the bathrooms we've already talked about are on the sides. There's also a gender neutral bathroom on the second floor. We're going to start with the first two tables, and then we're just going to continue to keep releasing tables by two. So we'll go these two, two, two. If you could, when you're done picking up your lunch, go all the way around to the back and then come in over here, and we'll try to have as much controlled chaos as we can. I think that's all I wanted to say. We are going to go for lunch until 1:35. However, about 1:15-ish, we're going to try to give our morning speakers a chance to answer some of the questions that you all have been offering in the Mentimeter. And we don't want to squelch whatever you're doing, but if we could kind of dial the volume down a little bit so we can have that Q&A. I'll also say it's quite possible we're not going to get all of the questions answered at that time, but we will commit to getting answers and then posting them at the website, our own website for the Behavioral Health Crisis Hub, where we'll have the videos and the PowerPoints and other materials related to today. So, tables 1 and 2, you are welcome to get lunch.